Well, good morning, good afternoon, and good evening. I'm Judy Wasserheit, the chair of the Department of Global Health at the University of Washington, the co-director of our Alliance for Pandemic Preparedness here at UW, and a member of the Consortium of Universities for Global Health Board. On behalf of myself and my wonderful co-chair, Rachel Stirk, the Deputy Director and Senior Scientist in the Center for Global Health Studies at the National Institute of Health's Fogarty International Center, it is a real pleasure to welcome you to this satellite on implementation science capacity building for global health and pandemic response. This satellite is co-sponsored by the Fogarty International Center, the University of Washington, and the CUGH Research Committee. Now, the genesis of this session is the recognition that the emergence of implementation science represents a major paradigm shift. In fact, some might argue that the emergence of implementation science could be considered one of the research advances with greatest impact during the first 2 decades of this century. As we will discuss during the next 4 hours, implementation science is a rapidly evolving, still relatively new, highly interdisciplinary research paradigm that recognizes and addresses what we might call the second valley of death for health interventions, that cavernous gap between the promise of scientifically proven health interventions and their successful implementation and scale-up in evidence-based programs and policies that achieve population impact in the real world. Implementation science provides a new lens on research to close what's been called this no-do gap by asking and answering with systematic, rigorous methods questions about how, rather than whether, interventions work or work best in different contexts. In a sense, one might say that implementation science is the signature science of global health and is actually the scientific frontier that will define what we can achieve in eliminating health disparities. Yet much of the development of the field of implementation science has been driven by investigators and research funding agencies in high-income countries. We still lack consensus on the definition of implementation science, particularly in the global context, in which the focus is often on large-scale programs and policies rather than just the clinical facility level. There's growing recognition that we may need to refine implementation science theories, frameworks, and models for optimal use in low and middle income countries. The mix and timing of methods may be different in LMICs as compared with high-income country settings. And while there's an urgent need to build implementation science capacity in high-income countries like the United States, the need is even greater in many low and middle-income countries. So today, we'll explore each of these dimensions of implementation science in global health. After setting the stage with discussions about the definition of implementation science and implementation science theories, frameworks, and models in the global context, we'll dig into the use of implementation science methods in low and middle income countries in a context that I think is top of mind for all of us, the COVID-19 pandemic. The devastating health, social, and economic impacts of this global health crisis have touched all of us, particularly those who are most vulnerable around the world. At the same time, during the pandemic, we've seen global research collaborations of incredible breadth, scale, and speed, and this has resulted in the unprecedented pace of scientific advances that delivered vaccines and other biomedical interventions in timeframes that, frankly, were previously unimaginable. But we also have seen the tremendous challenges of moving swiftly to implementation at scale with both these biomedical countermeasures and non-pharmaceutical interventions like mask use, physical distancing, contact tracing, in the midst of a global health crisis of this magnitude. We've never needed robust implementation science capacity more urgently. So with that, I'm going to turn this over to Dr. Stirk to comment on capacity building for implementation science, review our agenda, and introduce our stellar speakers, and then we'll be off and running for our satellite. Rachel, please.
Thanks, Judy. And I echo Judy's welcome to everyone here. So just with respect to capacity building for implementation science, as Judy mentioned, over the past decade, there's been a remarkable increase in interest in the field of implementation science, with commensurate increases in demand for training. Significant steps have been taken to build implementation science capacity in recognition, really, that a robust and sustainable workforce is required to successfully implement and or maintain health interventions of known effectiveness. So there are now an array of existing training opportunities globally and domestically, ranging from short courses to long-term degree programs and targeting professionals in practice and research. But despite increases in training opportunities, the demand continues to outpace the supply, especially for low and middle income country researchers. And there are a number of constraints in implementation science training that mirror some of the challenges Judy just mentioned, including the fact that the field lacks a standardized taxonomy for the science itself, including its definition and methodologic components. Training competencies are not well formed or differentiated for multiple end users, which impedes assessment of training program success. So there's also a lack, an important lack of critical mass of expertise in low and middle income countries, including insufficient mentors and support for mentors, which combined with limited funding opportunities to support training constrains effort to build a broad base for the field in low and middle income countries. So really increasing the number of training opportunities as well as broadening their reach to a wider range of learners would help address the recognized deficit in training and capacity. With respect to the NIH perspective, across NIH, we really have come to understand that none of our goals for overcoming global health challenges can be ultimately achieved without the learning from implementation science, and that are particularly important lessons about the role for implementation science in pandemic and crisis response, contexts where health delivery is even more challenging and fragile. With this recognition, NIH investment in implementation science over the past several years really has increased through trans-NIH programs and institute-specific initiatives. This is true as well at Fogarty, where the center's vision is a world in which the frontiers of health research extend across the globe and advances in science are implemented to reduce the burden of disease, promote health, and extend longevity for all people. Implementation science really has been a cornerstone of the Fogarty strategic plan since 2008 and remains a high priority, especially if we are to ensure that proven interventions are actually delivered and scaled up effectively. This challenge continues to require a cadre of researchers who are trained to generate the evidence required to move discoveries into practice, and increased efforts are now needed to catalyze partnerships and improve communication between the scientific community and program implementers and decision makers, so that science informs program and policy and the research is responsive to program and policy needs. Since 2008, we really have prioritized implementation science as an approach across all of our programs and have helped to advocate for the science and capacity building across the NIH. So with that, Fogarty we're really excited to be co-hosting this virtual meeting. And I'm going to walk you briefly through the agenda. Irina, if you could put the agenda slide up, and introduce our moderators and speakers so we don't dig into their specific session time. So next slide, Irina. So the agenda is broken into 3 sessions. The first session was really focusing on the definition of implementation science in the global context, and that'll be about 45 minutes. We'll then move into session 2, which will focus on implementation science theories, frameworks, and models in global context. And then session 3 is much longer than the first 2 sessions and is really intended to focus on implementation science and methods in the context of global health crises and really looking at the case of the COVID pandemic, which is at the top of everyone's mind. The last half hour of the satellite will be a general discussion about what we've heard and next steps and further questions. And just to say, in terms of the architecture of the agenda, for each of session 1, 2, and 3, we'll save some of the time allotted to that session for session-specific discussion and questions. And then the 11:30 to 12 will be more general reflections on the overall satellite. With that, I'll move in to introduce our speakers, and then I'll do a tiny bit of housekeeping at the end. So session 1 is going to be chaired by Kenny Scher from the University of Washington. And the panelists include Peter Tarutich, who is with the Ministry of Health in Kenya, Malambika Sarkar, who is with BRAC University in Bangladesh, and Elvin Gang, who is at WashU in St. Louis in the United States. And session 2 will be chaired by Brian Weiner, who is also at the University of Washington. And panelists will include Kunle Alonge from Hopkins University in the United States, Meredith Fort, who's with the University of Colorado in the US as well, and Roman Xu in Southern Medical University in China. And session 3 is chaired by Judy and me. And the panelists will include Peter Tarutich again, Linda Gale Becker, who's with the Desmond Tutu HIV Center in South Africa, Professor Liu from the Beijing University of Chinese Medicine and Pharmacology, Nadia Sam Agudu, who's with the Institute of Human Virology in Nigeria, and Patty Garcia, who's with Cayetano University in Peru. So we welcome all of our panelists and chairs, and thank you all for helping make this a dynamic satellite. Before I turn it over to Kenny to launch us into session 1, just a quick set of housekeeping procedures. If you could keep yourself muted, we would appreciate that. And we'll be using the chat for questions, so please feel free to keep them coming in the chat. And with that, Kenny, over to you.
Okay, well, good morning, afternoon, evening, wherever you are. Thank you to Judy and Rachel for putting together this opportunity to share in implementation science, which is a topic that I'm particularly passionate about. And as was noted in the introduction, the first session is going to focus on the definitions of implementation science, and in particular, definitions of implementation science in the global context. Now, there's a couple of reasons why we wanted to dedicate time to this material. The first is that, as Judy noted, the implementation science as a field is relatively new and has gained momentum over the previous 15 years. And as any field that is growing and is nascent, there will be shifts and refinements to definitions. And ultimately, we strive to forge a shared understanding of implementation science as essential for its future in the field. Now, much of implementation science, as has been noted, has been developed in high-income settings with notable differences in disease burden, health system designs, resources, research traditions, and other attributes relative to low middle-income country settings. And this flavors how people understand the motivations for and the essential elements of implementation science. Now, our agenda today will be first to review some of the definitions of implementation science going back to 2006. And I'll spend about 10 minutes going through these definitions. And this is really an attempt just to stimulate discussion and amongst the panelists. And as is noted, we have a fantastic group of panelists with Peter Tarutich from the Ministry of Health of Kenya, Malakiba Sarkar at Brak University in Bangladesh, and then Alvin Gang from Washington University. And these panelists all bring a distinct perspective to the discussion on what is implementation science and experience with leadership of high impact programs, as well as research in how to improve implementation and apply some of the dominant methods of implementation science to real world practice and research. And I'm particularly interested in hearing some of their perspectives as we try and forge this shared understanding of implementation science. And we'll have about 15 minutes of moderated discussion with these panelists and then open it up for 15 minutes of questions and answers from the audience. So I'm going to start with the definition that accompanied the launching of the journal Implementation Science back in 2006. Now here, the authors define implementation research as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services and care. This relatively new field includes a study of influences on healthcare professional and organizational behavior. I want to call out a few elements in this definition. Now, first is that it is focusing on translation of evidence-based interventions into practice to improve. The second is that it is focusing on improving healthcare and not necessarily all public health activities. And the third is a focus on organizations and providers as key for delivering evidence-based interventions. And hence that implementation science focuses on research on organizations and providers as drivers for the delivery of evidence-based interventions. Now, in 2012, Russ Glasgow from the National Institutes of Health at the time with colleagues provided an overview of where dissemination and implementation research is situated on the translational highway from the discovery of interventions to their development and then ultimately to routine practice at scale to lead to impact on population health. They note that dissemination and implementation science emphasizes investigation and understanding of the processes involved in the adoption, implementation, and sustainability of research. So looking at what we are now referred to as implementation outcomes. And they focus the dissemination and implementation research on the latter stage of translation, which include the third step of translation, or T3, where researchers are focusing investigations designed to increase the uptake and implementation of evidence-based recommendations into practice. And T4, where research is focusing on evaluation of the effectiveness and cost effectiveness of such interventions in real-world pragmatic settings and in diverse populations. They highlight that implementation science is a transdisciplinary endeavor, and that ultimately the process of translation is nonlinear, and each step reinforces the others through the sourcing of new questions for research, as well as new opportunities for application of research methods. Now, moving forward to a definition that was put forth in 2012 and reprinted in 2014 from David Peters and colleagues, and is a definition that has been articulated in a number of publications focusing on implementation science in the global context. Implementation research is defined as the scientific inquiry into questions concerning implementation, the act of carrying an attention into effect, which in health research can be policies, programs, or individual practices, collectively called interventions. So we see here a broader definition of implementation science, with the notion that interventions can be broadly interpreted to include policies, programs, or practices at the individual level. And we focus our research on how to implement or deliver these evidence-based interventions. Moving on, Thomas O'Denny and colleagues in 2015, including one of our panelists today, Alvin Gang, reviewed the literature on definitions of implementation science and HIV, and identified 69 articles with 73 unique definitions of implementation science. They conducted a network analysis of the literature or references and described loose connectivity across the references. They went on to define implementation science as a multidisciplinary specialty that seeks generalizable knowledge about the behavior of stakeholders, organizations, communities, and individuals in order to understand the scale of, reasons for, and strategies to close the gap between evidence and routine practice for health in real-world contexts. So I want to highlight here some of the commonalities that are starting to emerge in definitions. One is that it is a multidisciplinary process or field of study, that it is focusing on closing this no-do gap that Judy mentioned previously, that's focusing on research in pragmatic settings, and it introduces the idea of generalizability as a goal of implementation science, or through seeking generalizable knowledge, that there will be the ability to transfer results to other settings. Moving on, one of the definitions that many of us, I think, are aware of comes from the National Institutes of Health and the Dissemination and Implementation Science Program Announcement, PAR 19274. Now here in this definition, we see a separation of definitions for dissemination research and implementation research, where dissemination research is the targeted distribution of information and intervention materials to a specific public health or clinical practice audience. The intent is to understand how best to communicate and integrate knowledge and the associated evidence-based interventions. And here, this would be different from a process of passive diffusion, where instead we're focusing research on trying to improve the increased knowledge and uptake of guidelines and guidance around evidence-based interventions to practitioners who are working in public health or clinical practice settings. Implementation research is the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings to improve individual outcomes and benefit population health. And here we're focusing on the development and testing of implementation strategies for use, again, in clinical and community practice settings. Now, I'd like to end with a final definition, which is what we in the Department of Global Health at the University of Washington have been using as part of our training programs in implementation science, where we see implementation science as a systematic scientific approach to ask and answer questions about how to get what works to people who need it with greater speed, fidelity, efficiency, quality, and relevant coverage. Now, there's a lot here, so I wanted to go briefly through this definition and unpack it a little bit. The first is that we do see this as a systematic and scientific approach, where we are using research methods to answer questions about how to deliver what works, not if something works, but how to get something that works to where we want it to be. And we define what works to be those evidence-based interventions with a solid evidence base, generally from phase 3 randomized trials or efficacy trials. So we know that we are delivering something with a proven evidence base and getting it to people who need it faster, trying to close the translational highway to expedite the process of developing an evidence base of interventions and then getting it to where it is needed in a shorter time span with fidelity. So that includes the core components of the intervention that's needed to have an effect on individual and population health. That we do so with efficiency and maximize available resources, maintain quality, which is important for ultimately for population health impact, and then relevant coverage. And we modify coverage to note that it's relevant to, at times, specific populations across time and space. And then we also look at implementation science as a framework of state-of-the-art methodologies that we apply to improve this process as we go from intervention development to implementation to scale up, which is particularly noticeable as we're talking about the COVID-19 response. Now, I mentioned a framework of methods, recognizing that implementation science is a multidisciplinary field of inquiry. We will be drawing from the tools and research methods from a number of different disciplines. And this is, and apply these to delivery systems to, again, close a no-do gap or improve the delivery of evidence-based interventions at scale. And these include some of the more traditional public health methods like surveillance and data systems, impact evaluation, and economic evaluation, but then go beyond to include the tools from other disciplines. We have qualitative research as being core to understanding and improving delivery systems, building off of methods that come largely out of the social sciences. We include operations research and systems analysis and improvement coming out of the field of systems engineering and industrial engineering. And these are methods that have largely been used across the manufacturing or other industrial processes to improve efficiency and effectiveness. And when I put here operations research, really focusing on the definition of mathematical modeling to improve decision-making, while systems analysis improvement is more of a systems applied approach that includes quality improvement, which you may know as PDSA cycles or plan, do, study, act cycles, or quality assurance. We build from the literature in the management sciences to think about organizations and how to assess and improve organizational readiness for implementing change, stakeholder and policy analysis, dissemination research as part of our broader implementation science framework, which, as was defined earlier by the NIH, is focusing on how to improve the uptake of guidelines and knowledge on evidence-based intervention delivery among providers. And then a tool within dissemination research, social marketing, focusing on the demand creation amongst end users. So I'm going to stop here, and now we're going to move on to our discussion with our panelists. And as Rachel notes, you can use the chat function to ask any questions. And once we go into the second session of our discussion, I'll be looking at those questions and posing them to the review panel. The discussion panel. So the first question for our panelists, and again, welcome to Malabika and Peter and Elvin. Malabika and Peter from Bangladesh and Kenya, thank you for joining us at this later hour. Elvin from the Midwest, really excited to have you with us today. So the first question I have for the three of you is related to the motivations and interpretations for implementation science. Are there different motivations and interpretations for implementation science in the US versus global context, or high-income country versus low and middle-income country settings? Peter, I'm going to first give this question to you, and then we'll go to Malabika and then Elvin. So again, this question is, are there different motivations, and what are the different motivations and interpretations for implementation science in the US or high-income country versus global LMIC settings?
Yes, thank you, Kenny, and thank you, Judy and Rachel, for the invitation to participate in this panel. And this very exciting panel. Now, first, I think in terms of resource-limited settings, I wouldn't say there is really much discussion, particularly around the definition of implementation science, around the theory, the theoretical frameworks. I think people are just sort of busy implementing, so that there's not so much active discussion. But we do appreciate that, you know, there are probably different definitions of implementation science with, you know, nuances around them. But what is clear from our side is that there would probably be a unified theory of implementation science, and I think we just need to make sure that this discussion continues. But that said, what I do know, at least from our setting, is that we need to do a lot of work in terms of really making people in resource-limited setting understand what implementation science is, because there's still a lot of conflation with operations research. Whenever you talk to somebody about implementation science and say, oh yeah, we're already doing this, you know, we call it operations research. So, you know, of course, operations research as part of the methods for implementation science is not something that is sort of fairly understood, and is not sort of common, not common knowledge. But in resource-limited setting, I think the people are more interested around application of the implementation science methods that really, more than probably in other settings, that address issues around, efficiency, cost efficiency, task shifting. Because again, the idea there, probably more than other settings, is really you need to stretch the dollar a little bit higher. So you find that a lot of work that is done, a lot of discussions around implementation science, basically are around such areas, how to sort of really make the systems work a little bit better to achieve better outcomes. Thank you.
Great, Peter, thank you. Malabika, would you like to give your thoughts on this question around motivations for implementation science?
Yeah, thank you very much. Actually, I think if you look at the literature in the high-income country, or particularly the US, the implementation science is more focused the individual, the drug, the treatment. Whereas I think in low-income countries is more about health system. In USA, when they talk about more about the coverage, that how can they ensure the coverage, and for low-income country, we focus more on ensuring the equity. So in terms of the motivation and the interpretation, there's actually distinct difference. And like a nutshell, that high-income countries is more biomedical intervention, whereas in low-income countries more public health intervention, and context also very much important for low-income country because it varies even within a country across the different socioeconomic status, the gender, like the minority. So basically these are the two difference actually to me between the high-income country and the low-income country. Thanks.
Thank you, Malavika. That's great. Now, Elvin, I'd love to get your thoughts before we move on to the next question.
Thanks. So thanks for having me on this discussion, Ken, and a real pleasure to be here. I think this is a great question and one that bears quite a bit of discussion. I mean, in my view, there is some underlying shared common foundation for the motivation for implementation science and implementation research in both high and low middle income settings. We have evidence-based interventions that have not achieved the promise that they have for society. The reasons for that, though, could be quite distinct between higher income and lower income countries. And I think you'll get into that later. But one thing I did want to say is that particularly in this past year, as COVID has really changed the world in every way, in some ways, to me, the boundaries between higher income and lower income countries have become blurred. We have public health, we have shortfalls in public health in the United States that are not different than public health challenges in many places. We have supply chain issues. We have human resources for health issues. We have so these are all shared problems that the globe has to face and overcome. So on some level, I think that there are similarities here, but not to diminish the differences. And I think the rest of the conversation will probably be about those, because I do think that there are distinct differences and those we should pay attention to as well. So thanks.
Great, thank you, Elvin. Now, I wanted to now ask around core principles for the definition of implementation science. If we do think that there are some differences across the US and global context or high income and LMIC settings, and that flavors the interpretations of implementation science, noting that COVID has blurred something else besides what day of the week it is, it's also blurring the boundaries around determinants of our ability to get to scale with proven efficacious interventions. I want to ask what are your reflections on what are the core principles of the definitions of implementation science, and if we can start to tease out core principles and get to some more jointly shared or understood definition that could be universally accepted, or if it's going to be more specific to the global context, that is more specific to the global context. And we heard in some of the different definitions, some language that was not common across those definitions, like generalizability versus context-specific definitions, what pragmatic real world settings, and where those settings are, whether it's public health or clinical or both, or working outside of the health sector entirely. And then some other elements around implementation outcome strategies. And I would like to first ask you, Malabika, if you want to give your thoughts on potential core principles that define the field of implementation science.
I think before core principle, I think if we when I was listening to presentation, I think you actually showed the root problem of this implementation, because if you look at the definition, is it implementation science or is it implementation research? What is the difference between the implementation science and implementation research? Where implementation science stands without implementation research? We actually kind of, and still now, I think we're not able to answer those questions. And definitely, if you look at the definition, started from Glasgow in 2006, and Kunle is here, and David Peters in 2014, or recent Sally Theobald's definition, of course, is a little bit abstract, and it was important because it was an emerging field, so we are not sure. So I think we just first have to decide that what is implementation science, how do we kind of define it, what are the core principles of implementation science, and then what is implementation research, and what is the relationship between implementation science and implementation research. But definitely the core principle, I think it was like, I think Heather Colquhoun in 2014 article, I like the way she defined the core principle, that strategies and techniques for implementation, then conceptual understanding of the causal mechanism of the strategy and planning, and then the mode of delivery, and also that what is the intended benefit that we are actually asking for, and the role of different stakeholders. So I think these are the things that definitely the core principle, that implementation have to be the core, the foundation of implementation science or implementation research, because it's not about the individual patient outcome. It's about the implementation outcome. I think we have to be very conceptually clear that we are not looking for that one patient has been cured, and then is that how the function of an implementation strategy actually has been successful, which actually ultimately will lead to the patient better health outcome. Yeah, thanks.
Great, thank you. Now, Elvin, I'm going to ask the same question to you. And again, note that one of the definitions I went through came from Thomas O'Denny and the work that you were involved with him, which did raise in the definition the concept of generalizability. So I think you may have some particularly useful comments on what you think the core principles of a definition of implementation science should include.
Thanks, Ken. I think, again, a great topic and some provisional thoughts from me, recognizing that these things evolve. Let me speak first to the issue of kind of generalizability, and then come back to maybe a couple of other brief points about sort of core principles. I mean, I think that one thing that is notable about the term generalizability, I think, is that sometimes we think that for something to be generalizable, it has to be sort of invariantly true everywhere all the time, sort of like the way that physics or biology might be true, but generalizability is kind of a continuous variable. And I think in implementation research, we want things that are, we want knowledge and inferences that are more generalizable than just the very, very local context in which a study is done, even recognizing that we're not going to find something that's true for everything everywhere in the world. And that's still a valuable and important contribution to make. Now, I think that there are emerging methods that will help us do this better. I think traditionally external validity has been thought of as like, if you get a risk ratio of 2 here, is it 2 everywhere else? I think that there are methods for us to reconsider that. In other words, if we find it's 2 here, what can we use about that, the understanding the mechanism of how that 2 got to 2, to infer that somewhere else it's actually 3 or 4 or 0. And that's a harder task, but I think science needs to sort of catch up and have the methods meet our needs rather than our needs be circumscribed by the methods. And so, I think there's a way forward there. Specifically, I'm thinking of sort of, people have written about this, the scale up, scale out kind of idea, the adaptation idea, and also Judea Pearl's sort of transportability framework, I think, speaks directly to those issues. And then in terms of core principles, I think that, one enormous contribution of implementation research or implementation science is to ask the scientific community to formulate and conceptualize clearly what implementation strategies are, and then what implementation outcomes are for any particular scientific question. And some of this, as an infectious disease physician, and I don't know if this reference will be too esoteric, but before the Duke criteria, every hospital had a different definition of endocarditis, and you could not do research on endocarditis. And so we needed to conceptualize clearly what endocarditis was. In the same way now, we need to conceptualize clearly what any particular implementation strategy is, and therefore, with enough rigor, just like a drug, that it can be examined systematically and scientifically. And I think that's that has been an enormous sort of contribution, and I think a core kind of need and principle. There are others, but let me stop there, and love to hear what additional thoughts the other panelists have.
Great, I love that. That's generalizability is a continuous variable. I'll take that one and put it in my toolbox. Okay, Peter, over to you for your thoughts on any core principles for the definition of implementation science.
Yeah, thank you, Ken. From my perspective, I look at the foundational elements of the definition of implementation science, really composed of three things. Now, on one end of the spectrum is this notion of, it being systematic, of scientific rigor, that whole element that really talks about, that it's a formal process of scientific inquiry. I think that is something that we can all agree upon. But to me, I think it's universal. It applies across the board. And as we speak about this unified theory, I think that's something we can retain. On the other extreme is the outcomes of whatever you're doing in implementation science. Of course, we can agree and disagree as to whether we do it at organizational level or at individual level. But I think it's very clear that we're doing it for a purpose of improving health or improving coverage. There is a theme that I think can be consistent across settings. But I think it's the middle that where there's still a lot of discussion and probably context specific. And one of the things is the methods that you apply to them, of course, can vary depending on your situation. So I think that is something that I think is there. And then in the middle is, of course, this issue of implementation, really defining what is implementation in itself. Because again, that can have different contextual definitions in of itself. Of course, vis-a-vis scale up, and all of our things, should they be in the same sentence? Or sort of we tease them out? And then the whole discussion that I know Judy always likes to bring out is a question of really defining evidence and what evidence is sufficient. So I think in all that mix, there's a very gray area that requires a lot of debate and probably be very, very context specific. And but I do believe that this should be an agreement that it's a formal process of scientific inquiry, it's systematic, and then we should tend to agree that we are trying to alter positively, in a positive way, health outcomes, whether at individual level, organizational level, population level.
Okay, great, Peter. So this has been very useful, and I have one last question for your reflection. Given that we've talked about some of the different motivations and interpretations of implementation science and some core principles, what aspects of the definition of implementation science most needs clarification or refinement in the global context, and how might we be able to achieve this? Elvin, I'm going to ask you to go first.
That's a good question. I'll walk the plank on that one first. You know, I think I think one sort of tension in the field, I think, is the sort of dynamic between a system-centered approach and one that's focused on the intervention, right? So you can have evidence-based interventions, and we work our way back from the interventions to the strategies that are needed to do that, and then the health systems that are needed to support those strategies. And I think that that's a productive way of looking at the scientific sort of task at hand. On the other hand, you know, particularly in low and middle income countries where the systems themselves are in some ways frail and, you know, under-resourced, another way of looking at the important priority questions is how do you begin with the systems and work your way towards a system that can support many different evidence-based interventions. And I think that there are, I think that discussion, you know, I think is complicated. I mean, I think, you know, the former is easier to kind of like study and produce evidence about, right? The more distal in the delivery system, the more manipulatable it is, and the easier it is to get quote unquote evidence about it. But maybe the upstream things are the things that have greater sort of general value for a number of different implementation evidence-based interventions, even if you have a harder time drawing the line between the two. I'm sort of realizing that I may not be answering your question as I'm talking, but yeah, please redirect me if I have gone astray here. But I think that tension needs clarification.
Great. Well, I appreciate you taking the first stab, and I'm going to turn this over to Peter if you want to get some thoughts about how do we get to some sort of a common definition where we can, as a global community, have that shared understanding of implementation science.
Kenny, I honestly, you know, I mean, the same shoes as Alvin. It's a very difficult question, but I think one of the things is that we really have to unlearn, you know, what we've already learned. So I think circling back to what I mentioned before, we all come with this history of having done operations research and everything else, and that sort of clouds our thinking in terms of what implementation science is. So there has to be a change process in the global community and learning from the past. And then the other thing is that, and probably, I don't know, NIH would probably take this particular role. It's more of a leadership role, that if you have the different schools of thought together in a colloquium, and then you agree on some basic principles, as we mentioned before, and come up with a unified theory. I think it's possible. I do believe that if you look at implementation science, there's a veneer that cuts through, that we can all agree, depending on your school of thought, your you know, where you come from in terms of your setting. I still believe that there has just to be a leadership process that could bring people together and come up with probably you know, a Seattle Convention document, something like that.
Great, Peter. Thank you. And then Malavika, before we go to audience-directed questions, I'd love to get your thoughts on this question.
So the two things. One is, I don't accept it as a no-do gap. I think it's completely actually wrong definition when you say that implementation science, because we don't know. We have to know the context. We need to know about the strength of the health system, the weakness of the health system, and then come up with implementation strategies. So it is not a no-do gap. We don't know. So that's my first. We need to change that, like, you know, perspective. The second one, I don't understand the systematic uptake of the research. I do think it's too much abstract, and like, you know, and it's not only about the research, because when you say about the research, it's like researcher will come from the ivory tower and do the research. I think implementation science also encompass the capacity of the implementers and the policymakers so that they can do some kind of critical exploration, I would say, not research, and they change it. So rather than, I think we need to think about what should be the definition, but I do think that the backbone of that have to be the implementation strategy, which is the most important element of the implementation science or implementation research. Thank you.
Okay, thank you all. So I think what this conversation is demonstrating to me is that we still have a ways to go to define this process of how we're going to get to a standardized definition. It's a hard question, and there's a fairly fragmented community of implementation scientists globally, and in particular from high income and low middle income country settings, but a lot of food for thought on what is core to implementation science and considerations that I think will be useful as we go forward and continue discussing its definition. We have a little less than 10 minutes left, and I want to make sure we get to some of the audience questions. So I'm going to put up a question and ask any of the panelists to volunteer to give their thoughts. The first is related to dissemination research. And the question is, what are outcomes that are appropriate for describing successful dissemination research strategies or dissemination strategies? And you're not going to see this in the chat box directly as I've interpreted it, because there's been some behind the scenes direct messaging. Does anybody want to give their thoughts on dissemination research and outcomes particularly appropriate for dissemination research?
Again, the dissemination to me has a different vocabulary than implementation science. Dissemination is like a conveying the information, whether it's to the policymakers and our beneficiaries. So I don't know whether Elvin might kind of shed a light on that, but to me, dissemination, the word itself is different than when you talk about that. It can be part of the implementation science, but so I will pass it to Elvin.
You know, I think that I'm not an expert in this area, but I've heard some discussion about sort of an analogous set of sort of outcomes defined for dissemination to implementation. You know, how, so we have sort of implementation outcomes. You know, I think you know, dissemination, if we accept the definition of sort of a managed process of information promotion, exchange, and uptake, you know, I think is an integral part of the implementation process. But I think we all recognize that it's, you know, sort of like step one is get information and knowledge out. But then, of course, the challenges are kind of what we do after that. You know, I think a fertile area of discussion, and you know, have been interested in thinking about that, but I think it's sort of coming together, but happy to hear thoughts from others about dissemination outcomes.
Maybe one outcome could be the more funding for implementation science.
Yes. Well, let me move to another question, which is related to an implementation outcome of fidelity. And the question is the word fidelity appropriate in the definition of implementation research? Is there not a place for adapting research from other areas to the local context, thereby changing things? So one of the three of you want to comment on fidelity, the concept of core components, what can and needs to change across settings? I
like the fidelity actually, because the definition of fidelity is the paper versus actual implementation. And given that, you know, I'm working a lot in Bangladesh, and a lot of implementation, I was first 10 years, I was an implementer. There's a huge difference. And definitely from my experience, I found that if we can reduce the gap, the paper versus actual implementation, that will actually increase the effectiveness or efficiency of the implementation, I think at least 40 to 50%. There could be problem with the implementation strategy itself, you know, but overall, I really like the fidelity because it's meaningful when I look at the definition. Yeah, thanks.
Yeah, and I believe that, you know, the two are not mutually exclusive. So you need both. You need fidelity, you need adaptability and innovation. to me, I think it's something that when you are looking at the core intervention that you're looking at, to the greatest extent that it mirrors, what was studied in randomized control trials, you are able actually to measure its impact a little bit more in a more objective way. But I think when you look across, for every intervention, there would be a core that I think would remain, and then you can layer in a lot of innovations around it.
Just, I think to echo that, agreed with my other panelists. I think what needs to adapt and what needs to stay the same is a scientific question in and of itself for implementation science, and I think an important one. And I think we're beginning to unpack that, but need to take that farther empirically. Yeah, I mean, I've heard, I think if I may indulge in a 1-minute anecdote, I think to illustrate the Fidelity, I think adaptation clearly must happen, but there are certain things, whether it's to function or to certain elements of form, that for which fidelity would be important. So I had the interesting experience of going through TSA twice one time because I didn't have my identification at the airport, which is probably something not a lot of other folks here have managed to do. But I went through TSA and they did a I didn't have ID, and I went through in 5 seconds. They asked me 2 questions and I went. But then I realized I had to go out and go through again because I had left something outside. And the second time I went through, I was subject to 90 minutes of interrogation. So there was no fidelity at all between what they were doing, right? You go through once, it's totally easy. You go through another time, and that can't be a good system. So there, even at the level of form, there needs to be some fidelity if we want fidelity to an underlying sort of function. But what exactly those things are, I think, is an empiric question.
Great. Well, in our final minutes, I want to ask if there's, well, let me just say that in the chat, there's been a number of questions that have come up related to stakeholder engagement, related to the role of funders and funders of not just research, but implementation, largely being ministries of health. And so the importance of partnerships. And so I want to, rather because of being short on time, to ask another question, I just want to highlight a few elements that I think have come out of this discussion. One is that we are not, I don't think, close to a really formalized shared definition of implementation science, but I think there are some elements that we can pull out that are important for implementation science. I think everyone will agree it's multidisciplinary, that we really need to be thinking about the hard problems and coming up with effective solutions by bringing in diverse viewpoints, and that's going to be true across the high income or lower income country settings. That we need to think about the delivery systems themselves and how to capacitate and design delivery systems to be able to deliver not just one evidence-based intervention or practice, but looking at the whole suite of responsibilities of a delivery system. That implementation outcomes are important, and there's a lot of work that needs to continue to be done on defining those implementation outcomes and unpacking them, with Fidelity being a great example. We've talked also about implementation strategies and the need to better develop the evidence base on implementation strategies, to name them, and to understand causal mechanisms. And so I'm going to stop here in the interest of time. I really want to thank the 3 of you, Malavika, Elvin, and Peter, for joining us today on this stimulating discussion. I think it's a great launch to some of our next topics, and I'm going to turn it back over to Judy and Rachel. Thanks again.
Kenny, thank you so much. And thanks to, again, to Malavika, Peter, and Elvin. This was a great kickoff to our discussions today. And actually, I would urge the panelists from this session to look in the chat and respond if you want to any of the specific questions that have been put in the chat, if you have additional comments, because some of these questions and comments I think were great. So with that, we're going to pivot now to the second session, which moves from talking about the definition or definitions of implementation science in the global context to focusing on theories, frameworks, and models, most of which, again, have been generated in high-income contexts, and examine questions about them in terms of their translatability to the global context. And so with that, I'm going to turn this over to you, Brian, to lead off our next session, please.
Oh, good. Thank you so much, Judy, and good morning, good afternoon, and good evening to everyone. Pleasure to be here to talk a little bit about theories, models, and frameworks, and also hear from our panelists about their use of theories, models, and frameworks in their implementation, research, implementation science. Okay, I'd like to just set the stage a little bit here for the next 15 minutes and just provide an overview of theories, models, and frameworks in the field of implementation science and their use in the global health context. One of the distinguishing features of implementation science is the use of theories, models, and frameworks about implementation context, implementation processes, and implementation outcomes. And I'm going to use the terms theories, models, and frameworks interchangeably, even though there are some important differences among them. And I might slip into the use of the phrase TMFs, or for theories, models, and frameworks. I'll try to avoid that, but that may happen. I would argue, indeed, the use of theories, models, and frameworks is one of the features that distinguishes implementation science from, say, process evaluation. I would also argue that any research that strives to produce generalizable knowledge should be guided by a theory, framework, or a model. And yet, until recently, this was not often done. A systematic review of 235 implementation studies, was published in 2010, reported that fewer than 1/4 of those included studies employed any theory, model, or framework, and only 6% of them were explicitly theory-based. Now, things have improved since then, but nonetheless, it is the case that a lot of research is done without the use of a theory, model, or framework. And that's not because we lack theories, models, and frameworks in implementation science. In fact, in 2012, Rachel Tabak and her colleagues identified 61 theories, models, and frameworks that could be used for dissemination and implementation research. And a more recent review identified more than 100. Now, theories, models, and frameworks are useful because they help to frame up study questions and hypotheses. They anchor the study in the background literature and allow study results to be mainstreamed back into or integrated back into the literature. They help to clarify the constructs that are going to be measured, and they help to specify the relationships that are going to be, causal relationships that are going to be evaluated or tested. And with so many theories, models, and frameworks out there, the question naturally arises, how does one choose one? In 2015, Per Nilsson developed a taxonomy of theories, models, and frameworks in implementation science based on the primary purpose or the use of the theory, model, or framework. And he identified 3 primary purposes. The first is to describe or guide the process of translating research into practice, including implementing evidence-based interventions. The second is to understand or explain the factors that influence implementation success or implementation outcomes, more broadly speaking. And the third is to evaluate implementation, that is to determine the level or the degree or the type of success or outcome that is achieved in implementation. So under these 3 purposes, Nilsson identified several types of theories, models, and frameworks, including process models, determinants frameworks, classic theories, implementation theories, and evaluation frameworks. Now, process models specify the steps or the stages or the phases in the process of translating research into practice or the process of implementing evidence-based health interventions. Determinants frameworks describe barriers or facilitators, hereafter referred to as determinants, which influence the access to or use of evidence-based health interventions or other implementation outcomes. Unlike process models, which describe the steps or stages of implementation, determinants frameworks identify the factors that hinder or facilitate implementation. And determinants frameworks are very useful for assessing the context of implementation, guiding the selection of implementation strategies that overcome barriers or harness facilitators. Determinants frameworks can also be useful for explaining the level of implementation attained in a specific setting, or the variability in implementation success attained across multiple settings. Now, Nilsson's taxonomy also includes theories derived from other fields such as psychology, sociology, and organization and management science, which he calls classic theories. These are theories that were not developed to explain implementation per se, but rather they can be used or adapted for that purpose. And examples would include the theory of planned behavior or goal setting theory. In addition to classic theories, are theories that were specifically developed or adapted by researchers for use in implementation science, and Nilsson calls these implementation theories. And examples would include diffusion of innovation theory or the normalization process theory. And although less comprehensive than determinants frameworks, both classic theories and implementation theories offer hypotheses that relate specific aspects of implementation context or process to implementation outcomes. Hence, they're useful for the purpose of understanding or explaining what influences access to or use of evidence-based health interventions or other sorts of implementation outcomes. Moreover, some classic theories and implementation theories identify mechanisms of change, which can make them useful for explaining how or why implementation strategies work. Finally, evaluation frameworks, as the name implies, specify aspects of implementation that could be evaluated to determine or assess or judge the level of implementation success. So one way to think about these three purposes is that the process models really give you the how-to, really useful for guiding the implementation effort, step by step, what to do and in what order. Explanatory models give us sort of the independent variables. They help us to understand what are the factors that we must account for in a formative research stage when we're doing an implementation effort, and what are the factors in the retrospective or an evaluation phase that explain why we see the level of implementation success that we see. And of course, the evaluation frameworks give us the dependent variables or the measures and the metrics of implementation success or failure. So let me offer you some examples of different types of theories, models, and frameworks, starting with process models. The Quality Implementation Framework, or QIF, was generated by synthesizing information from 25 implementation frameworks about the procedures or the steps or the strategies that are thought to be critical for achieving what they call high quality implementation. The QIF identifies 14 critical steps or actions organized into 4 temporal phases that include: 1, initial considerations regarding the host setting for the evidence-based intervention; 2, creating a structure for implementation; 3, ongoing structure once implementation begins; and 4, improving future applications. These 14 critical actions are themselves temporally ordered into steps, some of which should occur before implementation begins, others during implementation, and still others when implementation is far along or complete. So process models, as I've indicated, are very useful for planning an implementation effort. Of course, as Nilsson observes, that process models describe a rational sequence of steps and therefore present sort of maybe an ideal view of implementation. Actual implementation, as most people know, is much more nonlinear and messy than what these process models describe. Switching now to evaluation frameworks, REAIM is a well-established framework in implementation science for evaluating the public health impact of a health promotion program or an evidence-based intervention. REAIM identifies 5 dimensions of a program or an intervention that signal its applicability, its scalability, its potency, and its sustainability in real-world settings. Those 5 dimensions include reach of the program within the intended target population, which is similar to coverage, the effectiveness of the program, the adoption of the program by targeted or target settings or staff, the implementation of the program in terms of its consistency and quality of program delivery, as well as adaptations and costs, and the maintenance of both program delivery and program effects. As an evaluation framework, REAIM is especially suitable for use in global health context, I would argue, because it balances traditional concerns about program effectiveness with considerations relevant to implementation and scale up, such as program coverage or reach in a targeted population. Let me just illustrate this for a moment. Imagine you have an intervention that is 100% effective, 100% effective. But imagine this 100% effective intervention is adopted by only 50% of the target settings or staff. It could be pharmacies, health facilities, really any sort of, or even individual providers. So adopted only by 50% of the target settings or staff. And it's only reaching 50% of the intended target population. And it's only implemented with about 50% quality or 50% fidelity. And it's only maintained at about a 50% level. So the public health impact of this 100% effective intervention is only 6%. That is, if you take a 100% effective intervention and you take 100, you multiply it by 50 and multiply it by 50 again and multiply it by 50 again and multiply it by 50% again, you get only a 6% public health impact. You can see why it's important that not only we have effective interventions, but that they are effectively implemented as well. Here's another widely used evaluation framework in implementation science. It was developed by Enola Proctor and her colleagues at Washington University at St. Louis. It lacks a name, so I call it the Implementation Outcomes Framework. And as you can see, the Implementation Outcomes Framework differentiates implementation outcomes from service outcomes and health outcomes. And it lists 8 implementation outcomes, some of these implementation outcomes are perceptual in nature, like acceptability, appropriateness, and feasibility. Others are more behavioral in nature, like adoption, fidelity, cost, penetration, and sustainability. And I think it's very important for us to distinguish between the health outcomes that an intervention might generate and implementation outcomes, or the outcomes that might result from an implementation effort. Why is this the case? Well, because when you implement a health intervention and you don't realize or don't achieve the desired or intended benefits from it, you have to ask yourself, is this an intervention failure, meaning an ineffective intervention, or is this an implementation failure where an effective intervention was simply not implemented well? And if you don't attend to and distinguish between implementation outcomes and health outcomes or patient outcomes, you're not going to be able to determine which of those 2 cases is occurring in this particular instance. Here are just a few examples of published research in global health that use REAIM or the Implementation Outcomes Framework. Now, moving to that middle column of Nielsen's taxonomy, the Consolidated Framework for Implementation Research is a widely applied determinants framework in implementation science with increasing use in the context of global health. The Consolidated Framework is a meta-theoretical framework that synthesizes 19 theories and frameworks in dissemination and implementation research. The CFR, as it's often called, includes 37 determinants organized into 5 domains: intervention characteristics, inner characteristics of individuals, outer setting, inner setting, and implementation processes. The CFR's widespread use results from its, I believe, comprehensiveness, its applicability, and its flexibility. The authors encourage users of the consolidated framework to select constructs from the CFR that are most relevant for their particular study setting, and to use these constructs to guide diagnostic assessments of implementation context, to evaluate implementation progress, and to help explain findings in research studies or in quality improvement initiatives. And it's that flexibility of picking and choosing constructs that are relevant, I think, that will come up as we talk about and hear from our panelists about the use of the consolidated framework in low and middle income country contexts. The consolidated framework is not the only game in town. The theoretical domains framework, or TDF, is another commonly used determinants framework. It synthesizes 33 psychological or behavioral change theories and organizes more than 100 constructs from those theories into 14 theoretical domains, including knowledge, skills, intentions, goals, and social influences. Now, neither the consolidated framework nor the theoretical domains framework hypothesizes causal relationships among these determinants. They are conceptual frameworks rather than theories, but both acknowledge that those causal relationships exist. And again, here are just a few examples of published research in global health that use either the consolidated framework or the theoretical domains framework. I won't offer any examples of classic theories that can be used to explain implementation. I've mentioned a few already, such as the theory of planned behavior and goal setting theory, but there are many more, including self-determination theory, the unified theory of technology acceptance and use, institutional theory, and coordination theory. I've already mentioned two implementation theories, specifically the diffusion of innovation theory and normalization process theory. These are theories specifically developed for and adapted to explain implementation. Now, here's a theory from organization and management science that identifies the organizational determinants of the effective implementation of innovations. This theory originated in the study of information technology implementation in manufacturing firms and has been adapted for use in the health-focused field of implementation science. And here's another theory derived from organization and management science that identifies the determinants and outcomes of organizational readiness for change. Again, this theory has been adapted from theory and research on business and social service organizations for healthcare delivery. And again, here are just a few examples of published research in global health that have employed one of the implementation theories that I've just mentioned. So it's important to note, as we heard a little bit in the first panel, that all or almost all of the theories, models, and frameworks used in implementation science have been developed in high-income countries that embrace Western ideals, values, and assumptions. Some caution, I think, is warranted in using theories, models, and frameworks in other countries and cultural contexts that differ from, say, the United States, the United Kingdom, or other Western high-income countries. The United States, for example, is characterized by a culture that values individualism and autonomy. Power differentials are devalued. Respect for authority and respect for hierarchy are modest to minimal. We have a cowboy culture, if you will. Likewise, the US healthcare system is highly decentralized and fragmented with a very odd mixture of public and private providers. Likewise, health professionals enjoy a high degree of autonomy and well-defined, even if contested, scopes of practice. And of course, relatively speaking, the US healthcare system is well-resourced. So it is important to recognize that commonly used theories, models, and frameworks in implementation science might need to be adapted for use in other cultures and other country contexts. And so with that overview, I'd like now to let me close this down here. Begin asking some questions of our esteemed panelists about their use of theories, models, and frameworks in their work in implementation science. And so the first question I'm going to pose is to Kunle. And actually, I'll ask all of the panelists to respond to this one, but starting with Kunle. Have you used implementation science theories, models, or frameworks in your work? If so, which one? And how did you choose that particular one? And then I'll ask you a little bit more about how well it worked and what kinds of adaptations you made or wish you had made in using this particular theory, model, or framework. Kunle?
Yes, thanks a lot, Brian. I think to your question specifically, whether I've used theories, models, and frameworks in my work, the answer is yes. But before I answer that question, I would like to preface it by picking up from some of the things that were discussed in the earlier session. Because obviously the use of theories and models and frameworks really is driven by the purpose, the goal that you're trying to achieve. And I think based on the earlier conversation, there is a tension between trying to maximize impact for a particular intervention or to addressing a particular health challenges in a specific context, as opposed to trying to generate knowledge that is generalizable across contexts. Indeed, in most of the application that I have used implementation, research, theories, models, and framework in low and middle income country setting, the emphasis is on really maximizing impact. So the goal is really to address critical bottlenecks and to address large-scale impact. And why I'm prefacing that is because it has implications for how we do apply those theories, models, and framework. Obviously, we want to maximize impact in a systematic way so that people can replicate some of the work that we do. So that goes again to some of the criteria for implementation research. It's a scientific inquiry, no doubt. The goal is to achieve better outcome at scale. So we're doing it in real life, in real world context, and so on and so forth. So we found that it's easier, therefore, to use theories, models, and framework that are meta-theoretical because, again, they allow for that flexibility to contextualize. And the context and the health system is really germane in the low and middle income country setting. In fact, when you mention intervention failure, you mention implementation failure, in an low and middle income country setting, you're thinking also about a system failure and health system failure, where there's no system in place to support intervention. So a lot of the application is really on working within systems, strengthening systems, and making sure that you have, by systems, I mean actors, infrastructures, relationship between different actors and stakeholders and infrastructures and sectors to maximize health for a population. So that's really where you're working. So to your question, one of the frameworks that we've actually found very relevant it's the CIFA, the Consolidated Framework in Implementation Research. So we had tried to look at, in some research, at the facilitators and barriers to a global health initiative like the polio program. And we're trying to do that across multiple countries. So some of my colleagues that we're working together on the project are here, Malabika, Yodi, they are here on in the conversation. And we found that the CIFA actually provides a menu of different constructs that are useful from the intervention characteristics to the individual characteristics and to the inner setting, outer settings, and so on. However, because the context really differs, we also see that a lot of those constructs really don't carry through. And we really have to, particularly when you think about the outer setting, which we take for granted in the US. I mean, in the US, in UK, in the Western civilization, we have some maturity of the outside setting. So we have an expectation that the government is in place, the systems are in place, things must work. And so therefore, the CIFA operationalization of that particular domain is really more restricted to organizations that are implementing. But in a low and middle income country setting, the policy environment is key. Understanding the larger socio-political context is key. So in fact, for the application that we use, we really have to completely repurpose the outer setting by borrowing constructs from other frameworks that are used in political sciences and so on. And again, that also presents the tension between whether focusing on biomedical intervention or acknowledging policy. In most of our setting, in almost all of the applications, we really are actually thinking about implementation science more from the traditional way that we think about it here in the US. But at the same time, we are borrowing principles, borrowing theories from policies, from social sciences, to be able to think about implementation at some higher levels beyond the routine care setting. So there are others that we have tried to use as well. The Proctor framework, which I like personally, because again, I think about it as a meta-theoretical framework. It's not really prescriptive, but it gives you a menu of different types of outcomes, placing emphasis on the implementation outcomes. And we've tried to operationalize that for evaluating community-based programs, for instance, in Bangladesh to look at drowning, and to try to explicate what is the mechanisms or pathways through which we see the effects, the large-scale effect that we see in real-world context. And therefore, we have to study implementation outcomes and really try to capture that in the pathway to effectiveness. So, so that's another framework. And there are others as well. But let me stop here so that others can comment as well.
Well, that's great. Thank you for that. And my sense too is in the use of the consolidated framework in lower middle income country context, or really any other country context besides, say, the United States or highly developed, or I should say high income countries, that outer setting is domain, which would include health system characteristics perhaps, as well as the policy environment and other factors, is one where there are relatively few constructs in the consolidated framework, and they do reflect more the interests and attributes of a U.S. healthcare system from which the consolidated framework was derived or synthesized, and so many important factors are perhaps omitted that need to be included, perhaps by drawing them from other frameworks as well. I'd like to come back to that, but let me go ahead and ask Meredith if she could speak for a moment about her use of theories, models, and frameworks in implementation science in the work that she's done in low and middle income countries.
Yes, thank you for the opportunity to be here. This is a wonderful session. I'm going to share with you one example that I'm in the middle of, and there are several colleagues who are here, so hopefully they can add in the chat or in the question and answer when we get to it if they have additional things that they'd like to share. But I'm going to talk about the use of the REAIM framework in Guatemala. And the project that I'm going to share with you is a hypertension control study that is being implemented with the Ministry of Health in Guatemala. The lead agency is the Institute of Nutrition of Central America in Panama, which is based in Guatemala City. And it's a type 2 hybrid cluster randomized trial, and it's in 36 Ministry of Health districts. So just to kind of give some context. And I'll say we started with REAIM, and then we expanded to PRISM, which is the context enhanced version of REAIM. So I think really building out from some of the comments that have already been made about the importance of emphasizing context. And in part that was related to when we did a needs assessment, initially we were applying the World Health Organization's health system building blocks framework to look at the context at multiple levels, really focusing on the health system aspect of context, but looking at the central level, the district, health centers, and health posts. And I think it revealed a lot of the importance of emphasizing aspects of context, and that was a shift that we made. And And I think certain aspects of it have worked well and others can be improved. One aspect that I think works quite well is the reach and representativeness part of REAIM, and thinking about it at different levels, so both the individual level and then the setting level. I'll say it works well, but we're still because it's complex when you get into the representativeness part of it. In particular, it's a work in progress, and we're drawing on other types of data that aren't available within the health system. So looking at the census, looking at other types of data that can help us to kind of enhance what we're capturing through the actual study. And then I think, we, with COVID, since COVID hit in the middle of this study as we've been implementing it, I had the opportunity to, one of my colleagues had the opportunity to apply an extension of REAIM that was written by Rachel Shelton and colleagues that focuses on equity and sustainability. And we looked at adaptations that, were not necessarily the ones that had been anticipated at the beginning. The COVID really made a big shift in how we were understanding adaptations, but wanted to look at the equity and sustainability implications of some of the changes that were being made due to COVID. And I think that was really helpful to look at that, but then just also recognize the importance of, frameworks can be improved, and adding these extensions to them, and looking at context, looking at additional aspects of equity, sustainability, things that may not be as well developed in the kind of the initial version of the framework is a recommendation that I have, and something that we've done in our work. And then I think in terms of PRISM, something that has been really increasingly important that we keep seeing as we're continuing to roll out this study is also related to health system strengthening, and the application of the building blocks framework is this aspect of implementation and sustainability infrastructure, and just kind of very concretely understanding whose job is it to do different aspects of the intervention and to implement it. What's happening in terms of data capture and the information system, and how can that be improved? And what can we leave behind in the future too, when the study isn't actually happening? So those are all aspects that I think have been especially helpful. I think it is a work in progress. We're always learning as we're applying it. And I think maybe I'll stop there to make sure we can get on to the other panelists.
That's great. Meredith, you mentioned a couple of points that are worth just underscoring. One is that these theories, models, and frameworks continue to evolve and develop even in the high-income country context as the developers and users continue to refine constructs, add constructs, and adapt them to our evolving situation, like the REAIM framework with respect to health equity. And the other is, I think, the appeal of these determinants frameworks and evaluation frameworks is that they, as conceptual frameworks, is they really give you a fairly extensive menu of either determinants or outcomes that one could select and use and apply in an implementation effort, whether you're designing it, carrying it out, or evaluating it. Probably also worth noting, though, that many of these determinants frameworks are merely syntheses or compilations of prior frameworks and theories. And so if it was in a prior theory or framework, it's included in the say theoretical domains framework or consolidated framework. And if it wasn't in a prior framework, then it isn't. And so these frameworks, while they do have lots of constructs, are not nearly exhaustive or comprehensive. There are certainly very important ones that are missing that would be relevant either in a high or low middle income country context. But in the application of these, I think we have an opportunity, especially in global health, to really highlight what are some of those factors that are missing that are really reflective of the origin, the health system and cultures in which these frameworks were developed. I've put some resources into the chat of some of the materials that you mentioned. Now, Roman, I know you are going to talk a little bit about a different theory that you have used, theory modeling framework, and that is the normalization process theory. which is great. I'm going to put you on the spot a little bit. It would be helpful if you could just say a word or two about this theory, and maybe its main constructs or its main theoretical propositions, just to orient folks a little bit to what normalization process theory is, and then talk a little bit about your experience using this and how you had to adapt or try to adapt this theory for the use in your particular research project.
Thank you, Brian, and thank you, our fellow panelists for the excellent comments. Just to give you everybody a context of how we are using normalization process theory, NPT. In China, we have, in addition to Western medicine, we have traditional Chinese medicine, which is not considered alternative medicine in China, but also the mainstream medicine with very formal training. So in Guangdong, one of the largest traditional Chinese medicine hospital, normally clinicians practice both Western and traditional Chinese medicine. They developed, based on the modern evidence-based medicine concept, the clinical practice guideline for stroke management using integrated Western and traditional Chinese medicine. So we are working with them, what is the best way to implement this clinical practice guideline in the county level hospitals. So that's where we came up with using a normalization process theory throughout the process of developing implementation strategy, understanding the barriers and the facilitators, and also using it as a process and monitoring tool to the end of even using that for assess outcomes. So we are applying it throughout the entire phase of our research. NPT is, we choose NPT because of a few natures of that is different from CIFRO or other frameworks, because it's explicitly a theory. So it explains from 4 major domains like coherence, participation, initiation, then reflective monitoring. So it gives you a very systematic way of thinking about how a new initiative can be normalized, then it becomes part of your routine. So until a point where you do not really feel something is an intervention, you feel naturally you're doing that, that is normalized, then that is you have a success in implementation. So that idea is very attractive to us. And the other reason for us to use this NPT theory is it has a good website with lots of resources and examples of how you can use it, even the instruments they have developed, the survey tools, etc., etc. So how we exactly use it in our research? This is a research at work. At this moment, we used NPT as a framework guided focus group. So we use NPT to develop our sort of the discussion guide. So the conversation with our clinicians in the focus group is guided by NPT. Some of the challenges of using that, we found out we did not do really some serious adaptation in that stage to the Chinese culture, but we found that very difficult to be understood by many people. And we have quite a bit of challenge in training our own staff. Even we have worked with one of the anthropologists who are very experienced in doing quantitative interview. That's difficult to use NPT. So we also found some of the constructs behind the NPT theory have sort of the overlaps in connotation. Very difficult to distinguish one from the other sometimes. So if we are going to do this in the future, whether we are going to adapt it, one of the work we are doing is we are trying to locate the literature to see how people from across the world is actually operationalize NPT theory, because it's a sort of theoretical and abstract, but how people use it for interview guide, use it for survey questions, then that reflects some of the concrete idea of how people are using it. Then we are going to see what are the Chinese examples we can build into those theories and make it more concrete for our researchers. So that's probably the way we're looking forward to do it.
Great. I do want to make sure that we have a little bit of time for questions from our those that are listening in here, and also a little bit of time to take a short break before our final panel presentation. Let me just look at the chat really quickly and see. One of the questions was asked, and maybe I'll field this to Meredith. Are all the re-aim dimensions weighted evenly, or would you consider weighting some of them differently in the application of this evaluation framework?
Yeah, so re-aim is pretty flexible, and it really depends on how you're planning to use it. And I think that's a really good question for a couple of reasons. So one is that you can definitely use re-aim quantitatively and qualitatively. You can use methods, quantitative and qualitative methods, to assess the different dimensions of re-aim. So it doesn't necessarily have to be a formula that to calculate public health impact. Not everyone uses all of the dimensions of re-aim because they may not all be the most applicable to what you want to be looking at. The other thing is there are, and I think this builds on some of the other comments that were made, there are inherent trade-offs really between the dimensions that it's important to talk with your research partners, the stakeholders that you really want to be kind of responding to what it is that they're most interested in, to make sure that you're emphasizing what's most important. So one of the, I think the trade-offs that was talked about already is really this trade-off between reach and effectiveness. That often we have a lot of emphasis on effectiveness. If we think about like a hybrid trial, the effectiveness of the health outcomes at the individual level often is how they're applied. But we may, if we're not emphasizing reach or representative as much, we may be just capturing the people who are easiest to capture, rather than really making an effort to, ensure more equitable access to the intervention. And so those are kind of trade-offs that are to some extent inherent to implementation processes and to that framework. And so it's important to really come up with a kind of an agreed upon approach with the team, the research partners, to define what's most important.
Right. One of the things I like about several of the frameworks and theories that we've talked about is that there are additional resources around them rather than just a list of constructs with definitions. Reaim.org, the website that I've just posted, the normalization process theory website as well, and the CIFER guide.org website, and I'll put that in the chat as well. They all contain additional resources to how to operationalize these constructs into measures or into interview questions. Some of them also include code books that you can adapt for, so interview guide templates, code books for coding qualitative data, even rating systems for sort of rating the strength at which a particular code or construct or determinant is present. All of them, I think, that makes them very appealing for use, even though they may have some limitations and require some adaptations for use in lower middle income country contexts. And I was resonating, Meredith, with the challenges of getting especially really good data for some of the quantitative assessments of re-aim dimensions, and those denominators are almost always very challenging to get. So I don't think that's a distinctive challenge in applying re-aim to lower middle income country contexts. Certainly we face that in high income country contexts as well. Let me just take a quick look here. We have a 15-minute break. Great. Let me just ask one more question of our panelists. Are you aware of any theories, models, or frameworks that have been specifically developed or designed in the context for use in lower middle income country contexts, ones that you would like to bring attention to the folks listening in here that they might not be aware of because they have not heard about it, or they've heard mostly about some of the ones we've mentioned?
So I think I can start off. In terms of specific frameworks that were developed in low and middle income country context. There are a couple. The challenge, however, is that they are not visible. So, and really that's what I would like to emphasize, in that because they don't fit into the ways by which implementation science has been discussed extensively in the literature up to date, because it's driven predominantly by the research that have been done in high-income country settings. Those frameworks are not visible, and I think it's something we need to redress. So, for instance, there is a lot of work that has been done in health systems research, which has a lot of, in low and middle income country settings, which are relevant, very relevant for thinking about implementation research. So we talk about the developed distort dilemma, which is really something to look at the tension between an intervention approach and the systems approach, and how to measure impact within those approaches. There are frameworks that have been used to describe implementation outcomes specifically in low and middle income country settings. For instance, thinking about how to operationalize something like acceptability and so on and so forth. So there are a couple, but I don't think that's really the issue. I think the question we should be asking ourselves is, how do we give a platform and visibility to the work that originates from low and middle income country setting, because we're not familiar with them. In a lot of cases, we are not familiar with them, and because we're not familiar with them, they don't get published, or they don't get talked about, and even though they are very relevant for those contexts. And that also has implications for how we train people, in terms of what are the competencies that we train people on, because if we are focusing on theories, models, and frameworks for our training, the question is, what are we teaching people to be able to problem solve within their context, and there are other ramifications as well.
Great. I see we're almost at time here. I just want to thank all of our panelists, and also note, emphasize what Kunle has just mentioned, that there are, I think, theories, models, and frameworks from related fields or disciplines that could be quite useful in implementation science, because they do attend to factors or levels that perhaps our current theories, models, and frameworks are less attentive to or don't attend to fully. And I think certainly the scale-up literature, the health system strengthening literature, and probably also the public policy and political science literatures as well, can really help us flesh out some of the distinctive features in the outer setting context, if you're using the language of the consolidated framework, where I think we could really use, that are particularly relevant in lots of countries, not just low and middle income countries, high income countries context as well, but for which our current widely used theories, models, and frameworks in implementation science are perhaps underdeveloped. So again, thank you all very much for your time. It was a really scintillating discussion, and I'm going to turn this back over to Judy.
Actually, I think Rachel's going to transition us to our break. Yeah.
Thank you. Thanks, everyone. This was a great session. We are going to take an 11-minute break. So if people want to go stretch, if you could come back at 11, and we'll launch into the third session at 11. And feel free to use the chat with questions and more dialogue during the break if you want. Thanks, everyone. Okay. I think I'll get us started with session 3. But before we do that, I think just important to reflect a little bit on the 2 first sessions and some of the things that we've heard. They were really useful, informative discussions, and I think our intention is to sort of think about those 2 sessions as we move into this session focused on implementation science methodologies in the context of health crises, and specifically COVID. We have an excellent panel that I think will provide really useful, diverse, and deep reflections on on implementation science and its utility in health crises and related to COVID. But before I sort of shift us to questions that we'll ask each of our panelists to answer, I just wanted to share some of what I heard that I think are key points as we navigate the satellite in general. So I think from the first session, Kenny reflected in the end that we're really not close to a formalized shared definition, and that really there is a lot of work to be done there. But there are some elements that seem to be common or came up multiple times, certainly around the idea of implementation science being a multidisciplinary science that needs to think about hard problems by bringing in really diverse disciplines. Really thinking about implementation science as nested in delivery systems and making sure to have clarity and understanding about what those systems look like and what their dimensions are. There was discussion about the importance of implementation science outcomes as well as strategies, and really digging deeper, I think, as a discipline to really define what those are, as well as understand the causal process of impact if you're thinking about an implementation science strategy. Some important questions, I think, that were raised and comments made about the tension between system-centered approaches and intervention approaches, and how complex it can be to think about a system-centered approach and how different it is to think about a health system in the context of a low-income country versus a high-income country. There was a question and then some reflections on the tension between fidelity and adaptation, and really trying to think about what needs to sort of remain the same and what needs to be adapted when thinking about implementation science and implementing a proven intervention. And that's a tension that I think is well thought out in the field, and there's certainly more growth to be done there. There was some commentary on rethinking generalizability and versus context specificity, and how there again is a sort of inherent tension in the discipline between those two things, but that really the field needs to come up with better methods to address the idea of generalizability in the context of implementation science. Then with session 2, there was a great overview of and examples of the use of theories, frameworks, and models. And Brian reflected on the fact that the use of these theories, frameworks, and model really is what distinguishes implementation science. He remarked on the fact that generalizability is important and sort of needs to be driven by theories, frameworks, and models, but they're not always used. And certainly we know there are many of these theories, frameworks, and models with many constructs that have been sort of hung on those frameworks. Many of the constructs have been developed in high-income countries, so there's certainly a need when thinking about implementation science in low and middle-income countries to think about whether these constructs should be different, adapted, are there things that are missing? So with those reflections, I think we want to think broadly about implementation science methods now and leverage the diverse and deep experience of our panelists. So with that, I'll turn it over to you, Judy, to launch us, to add to my reflections and or launch us into our questions.
Well, thanks very much, Rachel. That was a great overview. And actually, I think in the interest of time, I'm just going to turn now, and we're going to build on our discussions of implementation science definitions, theories, frameworks, and models. And in this third session, we're going to explore the use or lack of use of implementation science methods in implementation and scale up of interventions to prevent and control the COVID-19 pandemic across 5 countries on 3 continents. As Kenny highlighted during the first session, while there's general agreement that implementation science is highly interdisciplinary. Exactly which methods should be included in our implementation science toolbox is still open to discussion. And as a reminder, he showed a slide of one framework, the one we use at the University of Washington, that includes 10 core methods that are frequently employed. And for those of you who may not have been on, then let me just share that screen. And hopefully you can see this. Just as a reminder to folks, these 10 methods: surveillance and data systems, impact evaluation, economic evaluation, qualitative research, operations research and systems analysis and improvement from industrial engineering, organizational readiness for change, stakeholder and policy analysis, dissemination research, and social marketing. And the, this is just one approach to thinking about the kinds of methods that we might use. However, others might include different methods. I'm showing this only to set the stage as we turn to an in-depth discussion of the use of implementation science methods in the context of global health crises and related capacity building needs. So with that, let's dive into the questions for our distinguished panel members who bring tremendous breadth and depth of experience to these issues. And for our panel members, during this initial round of questions, I invite you to add any additional introductions that you want to make for yourselves very briefly, if you want to, before you respond to questions. So let's lead off with the first question, which is broadly, when you think about the COVID-19 response, focusing on interventions like masking, testing, contact tracing, vaccine rollout in your own country, what have been or are likely to be the most useful implementation science methods? And why don't we go ahead and start off? Peter, do you want to lead off?
Yeah, thank you, Judy and Rachel. Yes, when I reflected on this and looking at Kenya in particular and the strengths that we do have, I think one of the methods that most likely was applied and most likely could be strengthened to improve our understanding of response to COVID-19 is surveillance. And I think what we saw, and I think it's global, it's not only in Kenya, is that we had to quickly build capacity and infrastructure to be able to collect real-time data on cases and hospitalizations and report them on a daily basis over time. And I think that is something that I think it's global. So I think we just need to enhance on that. One of the things that I fancy a lot is that in terms of surveillance is that I think the largest amounts of data we do have now is data on temperatures. Because I think all over the world, we've deployed thermal guns and your temperature is measured at the mall, it's measured at school, it's measured everywhere. But I think this data is not really being captured in real time and probably just mapped out and should be able to actually identify hotspots where potentially new cases could be emerging. So I would imagine a situation where if these thermal guns had an inbuilt mechanism, GPS or whatever, or reporting this data in real time, and this gets mapped, I think that would be important. So really surveillance is critical. I think the issue of infrastructure to build on that surveillance and help us understand more of the pandemic, I think, is very critical. And then the other method is the impact evaluation. And of course, this is a pandemic setting. I don't think we would have had time, the luxury of time, to set up infrastructure of like doing a step-weight randomized control trials to measure the impact of the policies as whatever lockdowns and all that on the epidemic. But I think on the other side, based on the surveillance data, we have very large data set or time series data set that we can sort of retrospectively look at and actually measure the impact of those policies over time. I think every single country on earth has that database, and that come from a lot of sources. The other thing that linked to this surveillance and impact evaluation is use of crowdsourcing data from phones and and all that. I think this is something that is rich, and we should be able to build on as an implementation science community. Thank you.
Peter, thank you. And I particularly appreciate your highlighting one of the ongoing challenges of how we apply rigorous impact evaluation methods in the context of outbreaks or pandemics. It's something that's actually being discussed pretty intensively in some of the networks that NIH has set up here. I see Linda Gale nodding her head with all of this. So let's move south on the African continent to South Africa. And Linda Gale, thanks for joining us. And what are your thoughts?
Thanks, Judy. Hi there. Lovely to see you and the fellow panelists. And Rachel, thank you for having me. I was smiling because particularly the reference to not having the time to think this clearly through. And I was thinking, I have to really apply a whole lot of discipline to have the time to do this in a non-crisis time. And I was going to ask my fellow panelists how often you do the thing and then apply the theories and the frameworks afterwards, to say, well, this is actually what we meant really at the end of the day. That was going to be my honest owning up at this point. But I think we are getting more and more disciplined and being better about trying to at least use the frameworks or the theories to at least for diagnosis purposes. So as a diagnostic, and then really trying to say, how do we organize our thinking? And as someone who has been in the business for a really long time, doing mostly, I think, sort of health service research, trying to panel beat innovation into our health systems, I have come to appreciate the importance of these various tools to really help identify gaps we didn't even think or dream about, and to come up with innovation and ideas to fill those gaps that we didn't even think or dream about. So I really encourage everyone and I realize this may be the choir that we're preaching to, the fact that you even got on this call shows that you have awareness about this, but really encourage people to go down this road, even though it means you have to stop and breathe a little bit before rushing down the road to try and fix the problem. And that usually, I think many of us in this field, that's exactly how I describe us, is we're always wanting to fix the problem. And often we get ahead of ourselves. So sorry for that preamble, but I did feel that I don't for a moment believe that I'm even half an expert at this. We're learning as we go. But I wanted to, on following the comment that I just heard, I also wanted to raise one thing that I've seen working so brilliantly here in the Western Cape on the surveillance side has been sewage PCR. So checking to see how much COVID there is and following hotspots by looking at wastewater. So that has been just a brilliant way to sort of look to see where the next hotspot is coming up as an NPI sort of approach. And then I've loved the Google movement sort of idea of how much are people actually locked down and where is the lockdown working. And this is what led us on to implement something called TRACE. And here we are applying sort of process models. And what that study is doing is looking in our very crowded environments, because we immediately saw that the kind of NPI approach in our typical high density, low socioeconomic environments, those places we call townships here, that people were going to find it absolutely impossible to have social distancing and apply sort of NPI measures. And so we thought, well, what's the reasonable thing you can ask people to do? And so the way we've designed this is we have an index case, which gives us a household. We then go in and the household then gets randomized into a more intensive NPI support model versus the government's kind of hands-off, get it right, here's a leaflet, this is how you avoid COVID response. And in our Stop COVID model, we're looking through process evaluation at what is the kind of giving as much as we can, but then trying to find the reductionist point at what would be reasonable in these crowded environments in terms of household spread. So we are looking at how transmissible the virus is within a household context. Can we bring in some kind of measures to try and prevent household transmission? Indeed, how much has already happened by the time your index case, gets identified? How much is asymptomatic? How much is symptomatic? What do you need to do when, through the lockdown, etc., that household is in crisis? And how do you intervene under those circumstances? And as I say, the randomization factor here is on the household. And then we're really trying to map the process through this, hopefully at the end, kind of being able to step back. And through this, we're doing a lot of it telephonically. So we have these community healthcare workers who are in contact daily with the household on the phone, supporting them, helping them. We obviously arrived with a household package, which was disinfectant and sanitizers and so on. And then we have a social worker on the end of the phone also to intervene around sort of home crises. The trick here is to collect the process data, and this is being done by experts within our team to really try and put together what has been needed, what hasn't, looking at sort of the intensity of the intervention, and hopefully at the end of all of this we're going to be able to put it all together and figure out how much of an impact this has had, and also what is absolutely needed or possible and feasible and what isn't. We're doing some other biological things. Of course, we're looking at antibodies, immunity, T cells, etc. in the household. But that, just one option around this sort of process model approach, which means you need to come up with a concept. You need to make a diagnosis. What do you think are the problems? Then design your intervention, to my understanding, and then check through an impact evaluation, what has worked, but very important, actually collecting the data as you go in order to make sense of it at the end. So hopefully that is one sort of different approach and one idea around the NPI component.
Linda Gale,
Thanks,
thank
Judy.
you. That was a great example of an approach to impact evaluation. And actually, I really look forward to learning what you come out with this. Let's stay on the African continent and turn to you, Nadia, please. Turn to Nigeria. What's been useful in terms of implementation science methods? What has been problematic? What are your thoughts?
Yeah, so thank you, Judith. So for me, I actually have two country settings. I work in Nigeria, but I also work and live in Ghana. So I've been able to see what's going on in both countries. And I'll say, starting with Nigeria, that's where the bulk of my work is. We have a fairly well-trusted public health agency, the NCDC, the Nigeria Center for Disease Control. And really, this trust has been built, for years, and it came in very handy with the onset of the pandemic. And one thing that NCDC has done very well is to really have very good public health messaging on multiple platforms. From the beginning of the pandemic, they've been sending out text messages on a periodic basis on our phones. They have been sending out messages on Twitter and on Facebook. And they also have a very rich website that has all kinds of public health information, flyers and information for healthcare settings as well. How to protect yourself in very simple language with pictures and different modes of educating the public. So in terms of IS approaches, what they've really done is messaging. What they've really done well is messaging and public education of stakeholders. They've also convened trainings for clinicians, healthcare workers, first line responders, and even with the incoming vaccines, they have done trainings for healthcare workers and other public health personnel for them to be able to properly distribute and administer these vaccines to the population. And now switching over to Ghana, I would say that some of the things that have been done well is from the beginning, providing benefits and incentives to different aspects of the population, as well as supporting clinicians. So providing them with incentives, benefits, allowances pertinent to them working through this pandemic. And it has been very helpful in the response. The other thing too is in engaging local champions. And in that respect, we've engaged the biggest local champion, which is the president, who has been very, very prominent, a very, very prominent supporter of the public health measures in terms of vaccine. He himself took the vaccine yesterday, on camera for everyone to see. So, and all of those are carefully planned, and all of those are to really help with something we don't do as well. We do well with political campaigns, but not so much in public health. Is public engagement, community engagement, consumer engagement. And that has been, done quite well in this regard. What we could do better is again in the same line of engaging of consumers, i.e. community engagement, especially with respect to vaccine hesitancy and vaccine acceptance in both countries. And another thing that we tend not to look at a lot in public health or in health services research or even implementation science is really changing infrastructure. I think a lot of what we do in terms of our interventions is we work with the infrastructure that is on ground. We are supposed to integrate our interventions with the infrastructure. But sometimes a key problem is the actual infrastructure. It's either not enough or not well organized. And in doing some of these things, we have to reorganize the way we deliver health, or sometimes the very structure of our health facilities or our health system. And certain aspects have to be adjusted to make these interventions work well. And so I think some of that is really looking at it like a root cause analysis, but that involves looking at our actual infrastructure and areas where we need to change the infrastructure or add on to it. So I think I'm going to stop there. Thank you.
Nadia, thank you so much. Let's turn now to China, and Professor Liu, again, thank you so much for joining, especially given it's after midnight now there. But can you talk a little bit about how implementation science methods have or have not been applied and useful in the Chinese response to the COVID-19 pandemic?
Okay, thank you, Judy and Rachel. And yeah, for me, in my knowledge, the concept of implementation science is quite new in China. It's actually, we don't really have the formal information and the guidelines for this kind of a method. So it's a quite new concept, especially I learned quite a lot from the first two sessions of today's session. And secondly, I think for the control of the COVID pandemic in China, there are several major issues that have been happened. Especially China is one of the early epidemic impact countries for the COVID-19. And so I think first thing is that based on the previous knowledge on the principle of control of infectious disease, the public health and government regulatory, and to make the guidance for the control of the infectious disease. Because we have previous experience in control infectious disease back to the history, for example, tuberculosis and viral hepatitis, and also the SARS in 2003, and also the MERS and the influenza, etc. So there are several epidemic during the past decades. So we have accumulated a rich experience in control the infectious disease, and also based on the knowledge and also the previous evidence, or we could say indirect evidence from the other infectious disease, also the research evidence to formulate the guidance for this COVID epidemic. So in the very early stage, so that's, I think from the first report of the case, after weeks later, the first guidance have been issued by the government. So this guidance, of course, it's not based on the implementation science or the evidence-based, it's based on the knowledge and the previous experience, and also the involvement with multidisciplinary experts from the public health, infectious disease, virologists, and also clinicians. And so the first guidance actually, I think, play a very important role in the diagnosing and the treatment of the disease. And secondly, I think the public policy have played a great role, especially the lockdown of the city of Wuhan. It's a more than 10 million population city. So that's the first time I heard about the lockdown of the whole city from a lifetime for an infectious disease. So I think that's policy have played a great role in control this disease, because in that period, it's actually the time for the Chinese New Year. So you know there are millions of people will moving around in the whole country. So if that not happened, and you can imagine how the disease can spread rapidly through the whole country. So I think the lockdown has played a great role. And also some mathematical model have shown that through the lockdown, more than 90% of the cases have been reduced by only by this kind of policy, lockdown of the whole city at the very beginning. And the third one is a social media, I think, play a great role, because the first beginning we required information need from the frontline healthcare professionals, what kind of information they need for this kind of a disease. So in that way, we actually collect quite a lot of information from both international sources like Cochrane. They have a living systematic reviews undergoing focused on the COVID-19, and also some of the top international journals published research evidence, especially the rapid recommendation, etc. So that kind of information can provide to the public and also to the frontline health professionals. And also it's helped to update the guidance of the national guidance for the diagnosis and treatment. So you know, until now we have 8 different versions of the guidance. So about every month or even every weeks, the information in the guidance have been updated. So I think that could be considered as kind of a updating of the information or validated information or evidence to demonstrate or modify the guidance and also the policies. So that's also important. And other issues is the government have a strong regulation on the public strategies, especially sufficient provision with the personal protection equipment. So that's nobody said it's a problem, because you can easily get access for all of this testing for the contact tracing. Especially they involved the IT person and using the program for the personal iPhone system for the tracing of the contact, and also for disseminating information to the public. And of course, the very earlier publication of the virus sequence also stimulate the vaccine research. So at the moment, we have 3 different vaccinations have been partly approved by the FDA and have been used, even widely used in this country and outside of China. So I think we should learn from the implementation science, especially for the need of the concept of the knowledge and of the method series, to show that in future, or how to bridge the information gap, especially quickly provision of the validated information to the policymakers and also to the guidelines. So I think that's probably the future direction for us. And also we are working on the synthesis of the evidence. So we need to know what is the best way for dissemination the evidence or knowledge to the policymakers. So that's my previous experience. Yeah, thank you.
Chenping, thank you so much. There's many of us around the world learned from the way China has handled much of the early pandemic. But I am struck by your pointing out the limited use of implementation science in China, and I think China is not alone in that. I think that's true in much of the world at a time when implementation science methods could really be helpful. So thank you. I want to turn now to you, Patty, and to Peru, the third continent, and our fifth country for discussion. Peru has been hit pretty hard by the pandemic, and you have been very involved in the response there. I'd love your reflections on what elements of implementation science and methods have been useful, if any, and what the barriers have been. Please.
Thank you so much, Judy. This has been a really great discussion. And actually, yeah, I come from Latin America, the region that has been hit harder, I think, and I envy Africa with the great responses, China with the experience that had, and the other countries with the money they had to respond, really. But in Peru, for example, we lack the capacity to do molecular testing, okay? And that has been, it was not only resources, but also capacity, and the fact that there were no way, even with money, to buy what we needed to do molecular testing. For example, I mean, that was from the very beginning a real difficulty. And so I have so many things that I would like to say, Judy, and I hope we have time for the other questions, because but I want to focus first on lots of missed opportunities that we have had, that I have identified, because I think that there are so many of the implementation research methods that could have been used to confront in a better way the pandemic, okay? And we could start by talking about dissemination research. I think that could have helped us to target the distribution of information and fight the infodemia, to promote better practices, in public health, to avoid self-medication, which has been a critical issue in our country and in several countries in Latin America, and to improve clinical practice, like better use of clinical protocols or working protocols. But it was not really one of the things that the country approached. Then another method that I think we didn't use as well is social marketing. I think social marketing should have been used, for example, to promote the better use, not only the use, but the better use of masks, and create a demand. Even create the demand, for example, from something that cost the country a lot of money because we were investing on creating these transient isolation centers, okay? But that were not really taken by the community because they didn't understand what this was, okay? I think qualitative research is another thing that should have been used. Difficult in a situation of a pandemic, but still one very powerful tool to understand why people were not respecting the government recommendations of quarantine. At some point in the middle of the quarantine, we had more people that were in prison because they were not following the quarantine than people that were infected, okay? To try to understand why the mask use was not that popular, why people were not respecting social distance, and try to improve, with that information, policy implementation. Try to understand the barriers and facilitators, and also try to understand why people were not staying in these transient isolation facilities. You know, people were escaping. Actually, I have my own, I have done my own kind of like research. It's like, isolation is a terrible word. I mean, just maybe changing the name of these centers, like a comprehensive care for the people with initial symptoms, instead of saying that this was going to be an isolation center where you are brought alone with no family, maybe could have changed everything. I think we missed using methods that had to do with organizational assessment at hospitals and primary care centers. We put a lot of effort trying to create ICUs everywhere and bringing personnel that had never had experience on ICUs and very little time to try to implement that in a better way. And that has to do also with, some operations research, even related and maybe impact evaluation of the use of telemedicine and the adoption of telemedicine by providers and patients. There were some strategies from the government, for example, introducing these packages in which people were given door by door some pills for fevers, pulse oximeters, and in some areas, even hydroxychloroquine to be treated at their houses, okay? But although we were pushing to have some type of evaluation of this policy that was created just in the minds of somebody who wanted to do it better, it was impossible because there was no support. And that's one of my points here before I finish this part, okay? Because I think that what I'm trying to highlight here are some lots of missed opportunities. One of the big issues is using the word research, okay? Or using the word science that give chills to lots of people, especially people that work in programs or at ministers of health or at the Ministry of Health. So I think that's something that we need to deal with. It was so interesting that on the other hand, the economists, okay, which mainly are the ones that work, for example, at the Ministry of Education at this point in Peru, they were more open to understand and think about research and these type of methods that we started to use in order to make the decisions of opening or closing schools and at what level. It was so interesting that people in public health really had chills listening or just with the word research or science, while the economists were more likely to be open, but the economists are not really at the Ministry of Health. And I stop there because I do have some examples of things that work that probably we will have some time to highlight.
Well, Patty, thanks so much. You know, I think your perspective, particularly as a former minister of health in Peru, about the, you know, the challenges of trying to use research, but coming up against the public reactions and the reactions within some of the ministries themselves to what this means. As well as these missed opportunities. Really helpful. Thank you. Rachel, next question. I'm going to turn this to you.
Okay, great. Thanks, Judy. And thanks everyone for those really rich answers. So the next question I think really builds very seamlessly on the first question. And I think what we're interested in hearing from each of you is a little bit about a successful example in your country of the application of implementation science methodologies to enhance the response to COVID. I guess I should caveat the question with, if you don't have an example, I think our idea was to have you talk about, in an ideal world, how could you have used implementation science? But we wanted to get a little more specific than the first question. So maybe we'll start, Nadia, I'll start with you, and we'd love to hear your perspectives from West Africa.
Sure, thank you, Rachel. So building on what I said previously, I would say for Nigeria, one of the things that was done very well, and note that a lot of these lessons we are taking also come from our experience from HIV. There are a lot of parallels between what's happening with COVID with what's happening with HIV. Some lessons we should have learned that we still haven't learned, and then some lessons that we've learned that we are applying. So one thing is also expanding the health force by really, should I say, task shifting or expanding tasks to community health workers. And those were leveraged quite well in Nigeria, especially in the beginning when we started doing contact tracing. So we leveraged very much on community health workers who there were many of, who knew the communities and who could go out and do this work. So it did take some of the pressure off the rest of the health personnel for workforce who were really battling the disease, you know, and people coming into the hospital on that end. So that was one thing in terms of re-looking or reorganizing the health team to address a certain problem. The other thing was really using the NCDC network to scale up testing capacity and doing it state by state so that there was a point of reference for testing and response to the pandemic in every state, and in some states more than one center. This is separate from private facilities who also started doing COVID testing. I'm talking about the public health sector. For Ghana, one thing I would say is really the engagement of the public. As I mentioned, the president has been a very good and very visible supporter and champion. In addition to what I said he'd done already, he was also doing periodic national addresses about every 2 to 3 weeks on a Sunday evening, typically. He'll come out for about 10, 15, 20 minutes and give an update, plus also continue to champion the public health measures, vaccines, dispel some of the misinformation. But then again, this is only 15 to 20 minutes. So the ideal, now I'm going into ideal, would have been for the ministries of information, with the media, with civil society, with community-based organizations, to really do a media and information and disinformation, you know, debunking blitz, and continue to hit it from all sides, because these myths continue. They are really, really pervasive, and they are really causing people to not demand or have the uptake we need for, or the compliance we need for the public health measures, and more recently for the vaccines that are coming into the country. One other thing that I'll mention before we go on, ideally we are doing but could be better, is having more meaningful engagement of policymakers, not only in the national task forces, but really the other groups of technocrats and expertise people who are helping to make decisions. It is not enough to say the vaccines were not licensed for children or pregnant women, so, you know, tough luck, we're just going to leave those populations alone. No. And when you don't have enough representation in decision making from these groups, whether from pediatricians or child-friendly personnel, whether from women or women who are practicing maternal child health, whether from community members, it really skews the decision making, and you're wondering, what about the rest of us? Who's making decisions on our behalf? Who's advocating for our behalf? So one of the strategies, which also we can pull from implementation science, is really having representation at the decision-making level. And that's true stakeholder engagement, not simply a token engagement, but actually having this representation of these stakeholders in the decision-making process. Thank you.
Thanks, Nadia. And I do really appreciate your last point about stakeholder engagement, which I think comes up very often in the context of discussions about implementation science and how best to have it succeed. Maybe we'll hop continents. And Professor Liu, would you like to comment on any example, although you did comment earlier that there's a notable lack of the use of implementation science, and maybe you could talk about where it would be most useful in an ideal world.
Okay, thank you. I think in terms of efficient use of the limited resources, I think implementation science give us quite of an opportunity to make use of the limited resources. The first thing is that how to phrase the strategic question for implementation science. I think that's very critical and important for us, because as I mentioned, this is quite new for us. So the first thing is to understand how implementation science can play a role in the control of the public crisis. And second thing is that we need to understand what is the barrier and the facilitators when implementing the validated intervention or changing the policies. So that's, for example, we have the guidance, but the guidance on one way is not evidence-based. Another way is how to implement if we have the evidence and very reasonable recommendation in the guidelines, and how to implement and to get a wider audience to use this kind of guidelines. So I think that's maybe the kind of initial sort for future implementation science research in China, especially in face of the public crisis. Yeah, that's it. Thank you.
Great, thank you. And it seems like that would be useful in facing a next health crisis. Maybe Patty, to circle back to you and to Latin America, you mentioned having some potentially examples in your back pocket. We'd love to hear your reflections on any successes there.
Thank you. And actually, I would like to make give 3 examples. Okay, the first one, which also reminds me what Peter said, has to do with the use of data, surveillance, and data systems, okay, to guide certain policies. Actually, I think that was a very successful thing, okay. It was not only the data, but also a group of experts that was analyzing the data and guiding policymakers in order to take decisions about quarantines, about restrictions, about school openings or closures. And one of the very interesting things is that we built, as a country, we built on something that we started in 2017, which is the electronic death certificate system, which also was linked to a new policy during COVID, okay, that allowed people, that became kind of like an incentive for people, even outside Lima, in the rest of the countries. And I said people because it was the people and providers, both of them, allowed, this is an incentive in order to register anybody who died into the system and complete registered, so that the government will help the family with the funeral. So in that way, also the coverage of the death certificates improved significantly and could give us a much better view of what was going on around the country. So I know that Peru has been seen like one of the countries that have the highest mortality, but I think because of this issue, this link between a good electronic system, training of providers that could use it even in situations like in a pandemic, because you use it electronically, okay? An incentive so people will really, even if they died at home, we could have that information. And actually we do have the information, people dying at home and people dying at the hospitals, which is very important to understand what has been going on and the difficulties that we have had to handle patients at hospitals because we didn't have enough beds still. I mean, that has helped us to think about how to improve the capabilities. So this information system, the policy linked, the training, it has been quite, I think, important. And again, although we have been seen as, oh, so many deaths, I think probably we're one of the countries that has a much honest and close to reality data, which reflects what has been going on with deaths in the country. So I really think that is something that eventually, and we're trying to think how to even write it up, because I think it's critical. So everybody's using this system, plus the database is open in the website. It's called SINADEV. So anybody who would like to see it and analyze the data in different ways, right now, for example, we're analyzing it and we're seeing inequities between what has happened with women compared to men. It seems that women died more often at home and men more often at health centers. Okay, and the second thing is looking at the data also, women with higher education even more at house in their houses compared with centers. So I think that
Patty, you're
of the use and the power of data is the other problem that now, can you hear me?
yeah, now we can hear you. Your internet is a little shaky. You may want to try it without your video if that's helpful.
Okay.
I don't know.
Okay, let's try it. Can you hear me now?
Ah, yes, that is good.
Okay, so it seems that my face takes too much internet.
Yeah, but I love to see your face. It's a wonderful face. But
okay,
let's
so
hear your voice.
Okay, so the second example, so first example has to do with data to guide policies. The second example is how can you introduce an innovation in the middle of a pandemic, okay? Actually, in Peru, we didn't have, like several countries, enough ventilators. But there was this new idea that actually started in the UK of using the CPAPs, okay? As an alternative from ventilators. And actually, local innovators in Peru, these young engineers, came and contacted us. I said us because I was like chairing an innovation committee for the government, saying like, we have the capability with donations to create these CPAPs. So, and it was not that difficult apparently from what they said, but the problem was, how can we convince the government or the providers to use it, okay? So how can this be done? And actually, we work to, after we had a number of those CPAPs that even had a Quechua name, Quechua is a native language from Peru, so we could make it closer to Peruvians, okay? How can we try it? And we decided to do a feasibility study in 3 main hospitals, in 3 main places, okay? just to understand what were the barriers to the introduction, how could they be used, how to create a good training, and try to document if they will make a difference. And actually, this was done in a relatively short time, in a couple of weeks, with 3 researchers in 3 hospitals. And actually, from that, we created some training materials, but also we got information that helped to guide. Okay, it helped to convince and to make the Ministry of Health and providers understand, sorry for that, to understand the use that this type of innovation could have to decrease the mortality, because we were giving an additional tool even if there were no ventilators. So actually that was very successful. The Ministry of Health couldn't buy, because I mean, they couldn't find ways to procure these materials, but based on private donations, there were lots of these that were done, and it was very easily taken by hospitals in different parts of the country. And my third example is the introduction of the rapid serologic tests. Okay, that because we didn't have molecular tests, there was no way to make diagnosis, and we needed to know who was having the disease and trying to find hotspots, areas where people were getting infected or were infected, like markets, bus stops, or certain places. And actually a feasibility and an evaluation study of these serologic tests and showing the use helped for the introduction of the use massively in the country.
Thanks, Patty. You raised some really critical topics that I think we haven't gone very deep on, but certainly data around inequities and data to drive policy are critical in the context of a pandemic, as well as understanding how to introduce an innovation in such a rapidly changing dynamic. So thank you very much. Linda Gale, you mentioned some of the examples of what you've been doing, but I wonder if you could talk a little bit more about where and if you have been able to use IS methods to really inform your pandemic response.
Yeah, so Rachel, the one that just is right in my forebrain at the moment, because it's eating up all our time, is it's been our way to actually access vaccines in a short space of time. So for me, it's nothing short of a miracle. We were running the phase 3 ensemble trial, about a month ago. And the only way we could get access to a vaccine in a short space of time. We're very worried about a third wave. We have healthcare workers we really want to vaccinate before a potential third wave, was to repurpose research stock for a 3B rollout implementation science experiment, essentially. So we are enrolling 500,000 healthcare workers into a phase 3B implementation science program here in the country. What we're doing is the country has also, like Peru, and I loved what Patty was saying, is set up a system of being able to follow every hospitalization due to COVID. And obviously we know if those people are healthcare workers. So we have our DATCOV background happening. We're enrolling these healthcare workers, and we're unbelievably up to 80,000 after 2 weeks, enrolling them in a very rapid way using an electronic consenting process. We are following them up to look at obviously impact. We really want to know who goes down with the disease. There isn't a control arm. Obviously, we're unable to do that, but we're using background data in the rest of the population as a control, I guess, and then also healthcare workers who choose not to be vaccinated. And we are also checking for breakthrough infection. So any healthcare worker who develops COVID, we're getting hold of their swab and making sure that the reasons for breakthrough are rather that they didn't get the vaccine rather than they did. And obviously, if they did, then we need to understand that. Obviously, in everyone's mind is the variant and the various variants and what the impact is on our vaccines under those various situations. So it is an experiment of process as well as impact. And the process has been incredibly valuable. So as we've rolled out the vaccine in the early days, we're learning a lot about hesitancy, where the hesitancy is in the country. We're also learning a lot about ways to, we're doing some time in motion studies in the various vaccine centers to understand where we can sort out bottlenecks and problems. And I think this initial rollout is going to be incredibly important as the country moves to then try and vaccinate 40 odd million people in the next few months. So yes, that has been an extraordinary experiment. I don't think I've ever taken part in such a big experiment before. It certainly, and we've pivoted literally in 2 weeks. We have got the protocols approved. So probably the biggest thing about a pandemic and a crisis is you have to move fast. You have to know how to move fast. So I recommend people have boilerplates of these protocols sitting on shelves, so that you can quickly purpose them. It does mean you pick up the phone to your regulators and you talk to them about how they can help facilitate. You talk to your IRBs one-on-one to try and facilitate rapidity. And then as much as possible, you have an electronic system to gather data and consent people very quickly. So it's been amazing. And an incredible journey of collaboration and cooperation between government, academics, private sector, because of course the private sector needs to be involved in this as well. And then understanding sequencing. So who should get the vaccine first, who shouldn't? That's also been incredibly important. So policy coming in there based on science. So what does science tell us? That's where our hospitalization data has been really important to be able to feed that in to the model and understand how best to do that. So it's an experiment that is underway, and I look forward to also letting you know how that turns out. But we're very excited about being able to do this.
Thank you, Linda Gale. And I would be remiss not to acknowledge your presence here while you're doing this really important work, and that of all of our panelists and everyone. I think it is important to have these discussions and to help us prepare for a next crisis. So really appreciate you being here. And I think raising the idea of, and Patty, you mentioned that people have chills when you say the word research. And I think trying to integrate that can be really difficult in these emergency situations. So Peter, over to you. I'm wondering if you have or could talk about a successful example of using implementation science in pandemic response in Kenya.
Rachel, I think success is very hard to come by, but I think before I speak to that, I just wanted to cycle back to something that I think Patty and also Linda Gale mentioned, that, in the context of this pandemic, we saw a lot of challenges because our health systems are overwhelmed in terms of hospitalizations, and it's very conceivable that, there could be a lot of people who require hospitalizations and who hospitalized, and there could be a lot of people who actually required ICU beds and are not able to get. So of those people hospitalized and they didn't need to be. So I think the concept of differentiated service delivery for COVID-19, I think it's something that should be out there. I don't know whether Linda Gale has a boilerplate for that already, because it's a research question that I think is of interest to us and many other people around the world. And then, of course, we can apply different IS methods to evaluate whether TST for COVID-19 works. But just like in Nigeria, as Nadia mentioned, I think one of the things that we did fairly well in Kenya was the issue of stakeholder analysis. And yes, and much as it was not really done systematically, in the way that, IS sort of prescribes. But it was something that I think we did appreciate. There was a lot of that happening. And I think moving forward, particularly, what's been raised anecdotally, I think there is some vaccine hesitancy. And so I think moving forward, as the vaccines begin to arrive, I think that really needs to be on the, top priority for our agencies to be able to roll it out. But of course, injecting some rigor and some systematic element into it. But the thing I wanted to mention, although it's not really considered an IS method as such, but the field of mathematical modeling and all that, but the issue of social network analysis is something that I think we could apply a little bit more with COVID. Personally, I've been very interested to actually know, given that infections of this COVID occurs in clusters, really who infected who and at what time and when, sort of contextualizing COVID-19 incidents in terms of space and time. I think it's something that would be useful in public health. I know, of course, the more you collect very private data, the challenges around human rights and all that, so it's really a big balance. But we have to have a discussion as a global health community whether it's something that is worth thinking about. But certainly, I think using social networks to be able to pass information and disseminate information and demystify COVID and all its elements, right from infection to vaccines and how they work, is something that I think moving forward should really interest all of us. Thank you.
Thanks, Peter, and all of you for your excellent answers and examples. I'm going to hand it back over to you, Judy.
Thanks, Rachel. Actually, just Peter, I'm so glad you brought up social network analysis, because I think one of the things that's been fascinating, particularly for those of us who've worked for decades on HIV and other sexually transmitted infections, is thinking about the similarities and the differences with respect to application of social network analysis in terms both of spread of infections, in other words, a sexually transmitted pathogen versus a respiratory pathogen, and the flow of pathogens and the flow of information, and how there's so much we can learn about the parallels and the differences as we think about future pandemic disease prevention and response. So thank you for bringing that up. Okay, I guess this next question really delves down a little bit more into thinking about implementation science methods. And so my question for each of you on the panel is, has COVID in your context helped highlight important gaps in implementation science methods? What kinds of gaps are you seeing? Peter just mentioned social network analysis, which is a great lead into this conversation. And then, so what are the gaps and what does that imply about methods development needs? And this time, Patty, I'm going to start with you, if you don't mind. I'd love your thoughts about what the gaps are and what we should be thinking about in terms of methods development.
Yeah, okay, I have been trying to think about that. I think we have lots of methods that are very, very helpful, okay? But I guess what we are talking here is how can we use them in the context of a pandemic? And something that Linda said resonates in my ears. I mean, which is you have to act fast, okay? And you have to act in a way that you can have results, because I mean, it's an emergency, and you know that you have less resources than usual, because in the emergency, everything has to, I mean, people, you have less people are getting, your soldiers are getting wounded, right? And so how can we use these tools in a much more efficient way, okay? So I don't know if it is that we need more methods, but how can we use them in this situation in a much better way? So, and I don't have the answer, but there is another thing that has to do not only with the methods, but with the implementation of the methodology that has to do with implementation science. Just the fact, for example, that when you are trying to introduce these things that are research or science, you need to go through ethics committees, okay, or different levels of approvals that are not made for emergency situations, that because this is something that and the point that I want to raise is that I think we need to rethink what we are doing, or how can we introduce not only implementation research, but any type of research in the middle of a pandemic, and how human subjects or regulations or regulatory agencies need to adapt, and we have to think together about these issues, okay? Because timing is critical. The security of the workers that are working in the research is critical. So for me, maybe it's not really how many more methods we need, but how to apply them in a situation that is much more critical, and the component of human subjects on how you introduce this. I mean, how can we adapt these issues? I don't know how it is. I mean, in the US, for example, you have ethics committees that can give you exemptions, or understand that certain things that you do may not meet deep discussions, right? But in countries like mine, for example, where people don't trust each other, where you know that there is a lot of corruption, where you are concerned about abuse or abuse of power, etc. We have so many levels that create sometimes lots of difficulties to eventually introduce these type of methods. And that's why also the chills are coming from, okay? So these chills, when you talk about research or science, is because people think, oh, that's gonna take a lot of time, or that's not practical, you're not practical, okay? That is not going to give me any answers that I need to do right now. And then it comes also the issue of funding, okay? Because how am I going to allocate any funding to that component if funding is limited and this is an emergency? I just need to use the money on that side. So sorry, but I think all those things are connected. So I don't think it's a matter of just thinking about methods or frameworks. And I don't know if we're gonna have time for another question, but I just wanna throw another thing, okay? We have been thinking about frameworks. And we have been thinking about frameworks, and people have been using the word adapt. I don't think we have to use the word adapt. We have to rethink, okay? Adapt means starting from something that I don't think was made for low middle income countries or for emergencies. I think we have to rethink the frameworks that we need to use for implementation research in crisis, in emergencies, which are going to follow, definitely. And we have to think them from a different perspective. We have to think it taking into account the context, the settings, things like resilience, sustainability, and for me, champions, because we need champions in these type of situations, and the actors, which are not only the health workers, but as you have heard as examples, even community, the community, how the community is there. And that's a completely different perspective that we have about implementation research coming from other parts of the world. I mean, I started doing implementation research when nobody was talking about frameworks or theories, okay? I have my own. I haven't had time to write it up, but I think what is lacking is, I mean, when I have tried to use some of the ones that are around, I think they're failing because they are not serving to the purposes that I need in my own type of research or in the context that I work with, unless in an emergency.
So Patty, thanks so much. I like that emphasis on shifting from talking about adapting frameworks, theories, models, definitions, and methods to rethinking both for the LMIC context and for the emergency context. Great points. So Nadia, let me turn to you now, and I would welcome your comments about what you see as the most important gaps in implementation science methods, and what kinds of methods development needs you see, if any. Whether Nadia is muted, but I saw her a moment ago.
She was there.
She was there. Well, maybe her internet got mean to her and booted her off, and she'll come on. In the meantime, I tell you what, Linda Gale, I do see you. Could I turn to you, please, for your comments?
Yeah, and as it gets to the evening here in Africa, maybe you know, the internet gets stressed, perhaps.
Right.
Yeah, you know, so I was like Patty, and I absolutely have to agree with Patty on this, as somebody who, as I've already explained, you know, tends to go headlong into solving a problem, you know, and then fitting the frameworks afterwards. I would say what I want to say, and I realize that, you know, there's Brian and others on the call who may think this is sacrilegious. I'm not sure, but I do feel they're quite complex at the moment. So I'm wondering, in the time of a crisis where there's simplification and I realize that may be too much of a trade-off, because maybe you miss important things if you throw out a few determinants. And I say that not frivolously, but they feel at the moment quite complex. And I'm wondering if in this time of crisis, you just need a kind of, you know, ABC, a little bit like, you know, we've been teaching the vaccine teams in the last few weeks on resuscitation. You know, how do you keep it to a very simple acronym, and easily deal with that and easily get that going, and maybe, you know, reduce the time for preparation and all that, because there often isn't time for that. You often have to dive headlong, and then I absolutely see a place for iteration as you go, you know, tweak and fix as you go. Often there cannot be a control group or a contrasting group. So I wonder if, and I'm going to agree with Patty on this, we do need to say, here is a absolutely, you know, reliable framework, model, idea that you can use in this kind of scenario that is going to see you through to the end in the most robust way. It may not have bells and whistles, it may not have frills and what have you, but it's going to see you through. Because, you know, I just feel there isn't the same kind of luxury of talking to experts, trying stuff out, thinking things through, reading the literature. You know, you have to move. And so, yes, I'm going to, you know, back Patty on this one, that perhaps we can put our heads together and come up with something that's particularly relevant at this time. And maybe there is something that I'm just not even aware of, or something that could be dressed down or sharpened in some way. But that would be my my thoughts to this problem. Thanks, Judy.
Thanks, Linda Gale. So clear call for a streamlined version of at least a starting point for implementation science methods, theories, frameworks, and models in the context of a pandemic. And you know, I this is a discussion that's happening now way beyond implementation science. So thank you. Nadia, I think your internet was being mean to you and booted you off, and I'm so glad that you're back. I had turned to you just as your internet, just as we lost you. So let me turn to you now and invite your comments about the implementation science methods gaps and development needs, please.
Yeah, so I think that I'll say it in the context of the pandemic specifically. We had gaps before the pandemic, but there are some gaps that the pandemic has really highlighted. And one of that is simply the fact of how little we know about implementation science, especially in the application for policy making and public health around the world. I'll talk about my own settings. When you are doing implementation research or implementation science and talking with the same people, you might think there's enough that is known by enough people around, but actually there's much more awareness that needs to happen and learning that needs to happen beyond this relatively small group of us that talk about theories, frameworks, and models, to be honest. And in order to expand that knowledge, we really have to, there are theoretical implementation scientists, right? And then there's us who, I think of that, earlier on we were talking about, someone mentioned what is the difference between implementation science and implementation research. And the best way that I've seen it written in an article I read before was really that the implementation science was more or less the theorists, the people who come up with the frameworks and models and scrutinize them and edit them and change them and, you know, develop these things. I see myself as an implementation researcher in that I use these models and frameworks to design studies and implement them and to solve these questions. So people who are implementation scientists can also be implementation researchers, but I sit in the corner of implementation research. I don't develop the theories and frameworks, at least not at this point. So I think that in order to really close the gap with respect to how little implementation science methodology is used in a broad spectrum, we have to talk about it in terms of practical implementation science, or someone used the term pragmatic implementation science. So in that regard, we should be, COVID has really come to show us how little of IS we know, or how little that implementation science is used outside of, you know, a study that went in for review and has been funded and you're implementing it. And so that is the gap that I'm seeing. And we've literally had to change strategy on how we are teaching, learning, and implementing implementation science projects, which is a discipline focused on adjusting strategy to context. And we are not doing as good of a job in adjusting our strategy to the pandemic context. And so that is really the light that is shining on the gap for me right now. One other thing I'll say is in terms of methods is first to start knowing what implementation science is and understanding its practical use. I think we need to demystify implementation science so that more people will understand it and use it. And same thing, that people freeze and people get really intimidated when you start talking about it in the core way that we tend to talk about it. We need to really demystify it in order to disseminate its practicality, or in order to apply it practically. So what I'm saying is going to more, not forgetting the theoretical or the importance of the theoretical, but really preach more of the message of the pragmatic use for a broader group of people, so that it can literally be disseminated beyond the small group of us who understand or who attempt to understand the theoretical aspects of it. And this should be at different levels and in different disciplines. And in saying so, I think for my setting in West Africa, or maybe if I should, for simplicity's sake, generalize to the continent, we really need to have the brand of implementation science that makes sense to us. And somebody has said, you know, not only adapting, but rethinking. The principles are the principles, but the frameworks and theories, how we apply them, and whether we need to significantly rethink these frameworks and theories, which, as people have said before, were largely developed outside of, you know, my setting. We need to really use them in a way, or adapt them, or rethink them in a way that really does has high impact for us, and while we're still keeping to the principles of implementation science. Thank you.
Thanks, Nadia. Sounds like you're calling for doing some implementation science on implementation science, actually. Okay, so, right. Jianping, please, let me turn to you now, and I would love to hear your comments about this topic in these issues in the Chinese context.
Okay. Actually, as I mentioned, we are lack of use of implementation science in the public crisis, in this case of COVID-19. But I just identify, I think, two gaps for the implementation science opportunities. So one thing is that, as Nadia mentioned, that we need to give a good example of implementation science change actually the resources, or save the money for the healthcare system, or improve the cost effectiveness for the interventions, etc. So in that way, we can lobby the government for allocate some money for research in this area, because we need some resources to build up the capacity of the science, IS science, and also we need money to do research. So for example, in this crisis, the government invests a lot of money, research money, for the treatment, for the intervention. So the money goes for the innovative therapeutic approaches, but most of them are failure. And I think that's one of the lessons we should learn, that we should allocate some money fund for research on the system level for the public infectious disease issue. And second thing, we need some method from IS for how to implement or how to generate evidence for the infectious disease crisis. So as you know, the COVID-19 have a great impact on the healthcare system. So actually we noticed that there are several hundred randomized controlled trial registered in the platform, but actually very few can be implemented in the healthcare system. So I think it's the routine way of running clinical trial and generate evidence. So actually we don't have the very rigorous evidence for even the therapeutic approaches. So we face a challenge how to run in or generate evidence in that special critical situation. So people mention that the real world study can be one of the resources for information or evidence. But in reality, we also have a lot of challenge how to generate the real world evidence improved from the real world data into the evidence, real world evidence to change the policy. So that's also one of the gap that we need IS to help to generate the evidence. Yeah, that's it. Thank you.
Thank you. Really important points about both the evidence to encourage more investment by funding agencies to do the research, and also the linkage to policy and policy making. Peter, the final word on this one is yours. Your comments, please. You kind of let us off by talking about social network analysis at the beginning. Any additional thoughts, having heard the other speakers?
Yeah, thank you, Judy. I'll probably just build on what the other speakers have said. and not really focus on the gaps in the methods themselves, but on the environment around these methods. And I think I like what was said before, that in preparing for the next pandemic, it would also be ideal. I think we know in a very broad sense what would be the research questions that we need answered using IS methods in an emergency setting, in an epidemic setting. And so I think having like protocols that are like ready, the generic protocols that are ready, maybe can just be tweaked for the particular pandemic, I think would be something. You know, the boilerplate that I think Linda Gale mentioned, I think is a gap that we're noticing, and would improve that turnaround in terms of application of implementation science research. And of course, associated with that is that you need to have you know, nimble processes, particularly around approvals, ethics committees, and all that. You know, systems that are able to quickly you know, review these protocols and move them forward to the next level. But the other gap that I see, which is not really a method gap, is a gap on infrastructure. You know, the implementation science infrastructure. I think we need to build it. One of them, of course, is the issue of data systems. We've seen, I think, very great work, I think, that the Koreans did. You know, because they learned from, I think it was the Middle East respiratory virus, or I can't remember. They built an infrastructure, a digital infrastructure that was able to quickly pick up, you know, epidemics as they arise, and so deploying it also for epidemic control is something that they did. So I think building systems, electronic systems that are able to then capture data that we can then use eventually for impact evaluation. Like I mentioned before, you know, quasi-experimental methods like that we know do require sometimes that you need to have these systems in place. So I think building infrastructure so that it's there, so that whenever, God forbid, the next epidemic is upon us, we should have a very quick turnaround in terms of ability to answer implementation science questions. Thank you.
Thanks, Peter. That's actually a beautiful segue into the focus on capacity building. And Rachel, I'm going to turn this back to you now.
Great. So sort of shifting our focus, the last question before we open up for a discussion, and I would encourage people to, again, use the chat with questions, as we will have a little bit of time to have a discussion. But we're interested in hearing your perspectives about research, implementation science capacity in your country, and any gaps that you see or method development needs, although, and how you think we can best build research capacity to more agilely apply implementation science methods and use these theories and frameworks during a global health crisis in the future. And I think some of the comments that have been made, certainly Linda Gill, your comment about having a sort of reduced framework that's more nimble is definitely relevant, but interested to know if people are equipped to apply the methods, and or what can we do to be better positioned in the future. So maybe Linda Gale, I'll start with you and love to hear your reflections.
Yeah, thanks, Rachel. I think, you know, I'd broaden it for a moment to say just we had to learn on a very short space of time how to do research. You know, suddenly all research was stopped in our country, particularly. It was an intense lockdown. There was huge fear and the impossibility to sort of move. And it had needed strong advocacy to say, guys, you know, in the meantime, there's a pandemic going on, and we've got other dual epidemics going on in this country that, you know, need attention. So literally overnight, we had to figure out how to just do even any research. So I think we'll hopefully be better equipped, certainly for aerosol-borne you know, pandemics in the future around some of those aspects. The other thing that I think we really need to take on board is, I believe, certainly in my part of the world, and I would hasten to, bring others on the panel into this, and I suspect every country represented here on this panel is made up of a large number of pragmatists. So, we actually do some stunning work. I know when, my years of being at the International AIDS Society, that track D or track E, that is always implementation science, they're just huge amounts of abstracts and ideas that come from the countries that are represented on this panel at the moment. So I think there's tons of work going on. I think the gap is this, what Nadia was referring to, this implementation science, the way to do it in a way that you can optimally really get the best benefit out of it. And I know Alvin, Brian, others who are on the call today, we need to clone them, frankly, and, and get them sort of moved throughout the world. Every unit needs one, as it were, because I think some hands-on guidance on how to really exploit these methodologies, these ideas, and enrich the work we do. One, to help us publish it, in a better way in the future. But secondly, so that like can talk to like. When we compare notes and we think about ways how we do this stuff, we actually have some kind of common ground that we're working from. So I would say, we all the ways we could imagine, you guys are already doing some fantastic work in mentoring and helping, many of us to come to terms with this. But I do think more awareness, more mentorship, more training opportunities, more hands-on hand-holding as we do it. Actually, and this is where I say it frivolously, but I mean it, would be lovely to have a Brian or an Alvin walk a project as it goes. We're obviously going to need many more of them in order to do this. But I think this is how we're going to diffuse this innovation, because I feel like it feels innovative to me, but we would diffuse this innovation throughout our already good work, but I think we can do it better. So that would be my sort of parting shot. Thanks, Rachel.
Thanks, Linda Gill. That's really helpful, and certainly something we've heard in certainly some of our other implementation science networks, including AHISA, and surrounding mentorship and having real practical guidance, hands-on training. So thank you for that. Turning to you, Patty, would love to hear your reflections on capacity needs and/or gaps.
Okay, so I'm going to start by saying that words matter, okay? And I probably I'm bringing this again and again, and the issue is that because we use the word science or the word research, we are creating certain barriers to use these incredible tools to improve public health, okay? So I think we need to find some way of as you would say before, demystifying what we are doing, okay? And I don't know, as Nadia said, so, and I don't know if that has to do with changing the word research, okay, or science, and make it more human, less from the gods, okay? Because that's what we need. We need those tools to be used. So that's my first point. I think we still need a lot of work of building capacity, not only from the point of view of the researchers, but also from different levels. And I love that there is, I mean, in order for this innovation to be really introduced, we need to create those that are in the base, okay? Imagine a triangle, okay? The ones in the base will really advocate for these kind of things to be done, okay? That should be the public, that should be the policy makers. We need more tools of implementation to do things better. So we need to create the basis of this triangle. Then we need to create those that will be part of the use of those implementation research. So the ones that will help to do the research, the ones that are in the programs, doing the visiting the doors, etc., that will be part. And then we need to train those who will be doing guided research. I think we have been focusing only on the top of this pyramid, okay? And I think we need to go all the way down. And so that's my second point. My third point is that this triangle where we have all the people that are going to advocate, are going to be part of the research or use the research, and the ones that are going to be doing the research properly, okay? There are some people around there, like, for example, ethics committees that need to understand what we are doing, okay? And there had to be, if we are talking, this is in general about the use of implementation science methods in public health. But if we're gonna be talking specifically how to use this to have better responses for the future in situations of crisis, I think there is a need. And I really applaud you, Rachel and Judy, to try to bring all the experiences. And this is something that Linda and I were chatting, right? So we need to bring all the experiences of the things that that had happened, the things that we have done or we have not been able to do, okay, and share them and learn what are the lessons learned on how to do this better. Some of us probably were able to do something, okay, and maybe we need to change a little bit the theories and the methodologies and the ways. I mean, we were talking about even protocols, I mean, that are strict and rigid, I mean, how they could be adapted. And that has to be, I think, a community work, okay? It doesn't need, it shouldn't come from the north, okay, definitely. It should come from everywhere because the situations and the context had been completely different. And I hope that if we do all those things, okay, think about the training not only from the top, but all the other components that are important. If we try to share all these experiences, this could be like the first, I hope, one of the first places where we're starting to talk about implementation research in crisis and how to do it better, okay? Maybe we can be prepared for the next time to do a much better job and to really use these tools that I think are very helpful, okay, but maybe not that practical for low middle income countries and less for emergency situations. Maybe with better tools and using the experience, we can do better the next time.
Thanks, Patty. And I think we're starting to see some of our thoughts converge, right, on some themes that are coming up. And so I think the takeaways from this will be really useful and interesting once we have time to digest them. Nadia, maybe I'll turn it over to you. We've had a lot of conversations about capacity needs for implementation science, but interested in your thoughts, especially in the context of COVID. What are the sort of low-hanging fruit capacity needs that you think would help in the future?
Thank you, Rachel. And you know, I love this question because this is, you know, one of my personal goals and missions, and the mission of CUGH, which is the Central and West Africa Implementation Science Alliance. The issue of capacity building really has to start also with consideration about the curriculum that we are using for that capacity building. So that goes to a lot of what is said, especially by Patty as well and other people here, saying that we need a curriculum that still builds on the principles of IS, but with theories and frameworks that are very, you know, South-oriented. And even within the South has different settings. It's not one homogeneous group. So that we have frameworks and theories and ways of organizing implementation science methodology for application that really make sense to those settings and are rooted in those settings. And that will help with people being able to interact with that curriculum and learn it and apply it. So that's one. The other thing that I'm looking at is, so how do we build that capacity? Assuming we have the curriculum already. Really, I think we should, and Patty also said it, we should do this at different levels. We have been focusing on a certain small group of people at the top, and me being in parts, I also blame myself. I have to change my approach to the capacity building. And by looking at it at different levels and in different disciplines, we say implementation science is multidisciplinary, but there are certain groups of people that are overrepresented in implementation science, as in being the ones to lead these projects and drive these projects and drive the decision-making in the application of these projects. So I have chosen to work, to work on the capacity building through academics and public health programming. But even in that group, I'm looking at people in behavioral science. I'm looking at people who are health economists. I'm looking at people who have been doing advocacy and community building for years. I'm looking at youth as contributors to implementation science learning and application. And those are all the different groups of people whose capacity can be built. The other thing that I want us to think of is when we are building capacity, we should go beyond simply building capacity, but to have that capacity be able to be applied. And that is skill building, that's application. There are people whom we've been building capacity and building capacity and building capacity, but we have not tested the ability for them to actually apply that capacity and gain further experience through the application of that capacity. Building capacity doesn't stop at getting a degree in X, Y, or Z discipline. You have to use it. And in order to be able to use it, you must be given the opportunity to use it. And the people who are making decisions about public health programming, especially, should understand your importance in that space and give you the opportunity to use it. So part of having good public health is allowing, whether an expert doesn't mean, people in academia already. They are experts at different levels, allowing them to do their expert work in conjunction with other people. And so the building capacity is not simply, we train 12 people to learn this and great job. No, what have they used it for? What is their impact? What is their productivity? How have they changed health indices? How have they changed the status quo for pandemic response? Where are those technocrats? You understand? So that really has to happen. And in settings where technocrats are not allowed to do their jobs, you can see the mess. You can really see that. So there should be a pipeline from the beginning to the end product. And whoever is in that pipeline, there should always be a critical mass of those people. That number of people must not drop under a certain level. And in some places, we haven't even built the critical mass yet. And so really that's the my thought process behind capacity building. It goes into application, skill building, and keeping a certain critical mass below which you do not go. So I think I'll stop there. Thank you.
Thanks, Nadia. And thanks for your thoughts on looping in stakeholders who use research evidence into the research process early on. And I think it's absolutely critical and something that's hard to do and something that certainly some funders like NIH don't incentivize as well as we could and should, certainly in the context of implementation science.
Can I add one more thing? Sorry.
Sure.
So back to funding the trainings and capacity buildings. I also think that we should look behind providing these fellowships with a certain age limit. A lot of fellowships that are available are for 35 and under. Many of us have not been 35 for many years. However, we still need to be able to get the opportunities. Yes, we still need to be able to get the opportunities to add implementation science to whatever expertise we've already collected. I know a lot of people around my age or wherever I am in my academic life or even higher who find value in adding implementation science learning to their skills, but they don't have the opportunity because a lot of these opportunities are for younger people. However, it is this age group, a lot of them, who are making decisions. And so if they don't understand what implementation science is or don't have the opportunity to learn, there's going to be a disconnect. So we should also create some opportunities for mature students to be able to learn whether short-term or long-term programs. Thank you.
Rachel, and I'm sorry, but I think that's a very important point because they can become also rapidly mentors for those young people because they are in the positions and then they will have the power of knowledge. So I completely applaud you, Nadia. That idea.
Thanks to you both. That's a really important observation and thought, certainly for me to bring back and consider. Jianping, would you like to make some reflections? It'd be great to hear what your thoughts are on China. And noting just, we are sort of eating into our discussion time, but I think that these are really important reflections that you're all providing. So over to you.
Okay, so I think I have only just a brief comment in the China's situation because we are lack of the this kind of new science for us, and I think the general capacity building is necessary and important, especially for the general knowledge of this new science. And secondly, we perhaps need to find a suitable methodology or framework for the resource limited setting because they have a different healthcare needs for this implementation science. And thirdly, as Professor Roman Shi mentioned, he has a pioneer project for implement the clinical practice guideline in China. So I think that's also one of the area that we can start with, because in China we have more than 700 clinical practice guidelines for Western medicine, and also we have more than 800 clinical practice guidelines for traditional Chinese medicine. And of course, there are some guidelines for integrative medicine as well. So for the same disease, we have different guidelines. So I think perhaps in future, we should find a way to implement how is the best way to implement the guidelines for the same disease with different guidelines. So that's also one of the concerns from my point. Yeah, that's it. Thank you.
Thank you for that reflection. And Peter, over to you. Would love to hear your thoughts from Kenya.
Yes, thank you, Rachel. I think in terms of capacity building for implementation science, I know a lot of work is being done already through Fogarty and through University of Washington and others, not only in training high-level implementation science, but also building capacity for several cadres at different levels. So I think that is good, and that should be consolidated. What I see, and I'm happy again that in implementation sciences, there are several networks and collaborations that are coming up. I think also that should be, as part of capacity building, that's something that should be enhanced. And I saw how the basic scientists really collaborated at the beginning of the COVID pandemic, and were able to do sequencing, and they were able to share their results of their sequencing, and that informed, of course, diagnostics and also prototypes of vaccines. So I think collaboration and enhancing that, I think is something that we can continue. I know we already have several alliances. If we could expand these and ensure that these alliances are, some of them would actually be embedded within the ministries of health. They could take the lead, and of course with support from local universities and academia. I think it would be good. I'm happy to note that there's that West African Alliance. So I think when we do this, I think we create opportunities for people to come together to exchange ideas and run webinars like this and do many other things, do protocols together, do publications together, and basically I think improve capacity across the board. Yeah, so I think I'll be brief in my comments because I know time is not on our side there. Thank you.
Thanks, Peter. And your perspective from the ministry is well noted and important. I think so. I would just encourage any last minute questions in the chat, and then I think maybe we could open it up to the panelists for any closing comments or last comments you want to make before the satellite closes. And I might invite all of the panelists to comment. Not that we have time for all of you, but if you have a comment, feel free to unmute and share.
Rich, I just wanted to emphasize a point that one of our participants raised, the question of funding for implementation science, which I think is important. And I've also raised this before, that in an ideal setting, just like the way PEPFAR does, that it sort of funds, the HIV programs, but also funds evaluation, sort of integral to each other. I think moving forward, from an advocacy perspective, ensure that even as global agencies are funding programs in countries, that should be tied almost, an implementation science method way of either evaluating the program or announcing.
Thanks, Peter. I may have missed a little bit of what you said, but I think you were noting the importance of making sure that there is enough funding available out there. And I appreciate that very much. Linda Gale, I see that you have a comment.
So Rachel, it's going to follow on Peter's. I think it would be remiss not to advocate again that those agencies that, and I know it doesn't apply to every country on this panel, but certainly, for example, the Global Fund for HIV, malaria, and TB doesn't necessarily use the opportunity of their implementation to conduct implementation science. So it's a policy that they don't want to spend money. I think, I forget who said it earlier, that governments, and donors aren't always keen to do this. And I think this is a huge missed opportunity as we roll out these enormous programs, some of which have been done during the COVID time. And we haven't used the opportunity to add an implementation science component to it, I think is something that needs to stop. And we need to, again, create awareness of the value of this amongst donors as well as governments for this reason.
Thanks, Linda Gale. That's a useful comment. I see also Kunle, do you have your hand up?
Yes, that's correct. I think this has been a great conversation in very many respects. And one of the things I do like to emphasize again is maybe we need to shift our focus away from trying to find a uniform definition of implementation science across context. I think that has really taken a lot of attention away from the issues that we should be focusing on. It's clear from all of the conversation that we've had today that the notion of implementation science is multi-theory. There are a lot of theory that applies from different disciplines, and there are also a lot of methods that also applies. And so therefore, we should not be trying to define or make implementation science exclusive by the set of theories, methods, or framework. But maybe what we should really be thinking about is what are those principles that are common across the different settings, and to allow people to innovate even within those principles. And that's implication for what gets funded, because again, when we submit grants, they go through some rigorous reviews, which are based on specific paradigms. I think we need to shift that. And it also has implication for how we train people. I was so happy with some of the comments that were made here, particularly some of the things that Nadia said. We looked at competencies for implementation science training. We were working with some groups in low and middle income country setting. And we found that all of the competencies or curriculums that are designed are based on theories, models, and framework from high income setting. And while the gaps in low and middle income country settings are actually around the health systems, around stakeholders, around context, around ethics and communication. So there is really a need to rethink, like Paddy said, to rethink not just only how we do implementation research, even how we train people. And lastly, I would just want to emphasize the importance of teams. And I think it's something that was, people kind of were touching upon, even as some of those points were coming up. Individuals don't do implementation in most settings. It's teams that do implementation, either multi-sectoral teams or teams across different sector or disciplines and so on and so forth. So similarly, when we're training and supporting building capacity, we should be thinking about teams and less of just single individuals, and to think about how to foster relationship between traditional researchers, practitioners in different settings, so as to demystify the whole notion of an elitist kind of way of doing research. Thanks.
Thank you for those comments. Also really, really helpful. And just briefly, since we're rounding, I guess we rounded over the hour by a minute, just to say this has been a really rich discussion. I sort of wish we had more time, although I don't know if people could sit longer on Zoom, but I think a lot of important themes have come out that I think I'm certainly looking forward to thinking through with the team. I just wanted to thank all of the panelists, certainly, but I think we've heard a lot about the implementation science needs in the context of low and middle income countries, and also overlaying a pandemic or crisis response. I think we have some growth and some thinking to do to position ourselves to have more success in the future. So I'll hand it over to you, Judy, for your closing thoughts.
Well, thank you. I personally have been really energized by this very dynamic, truly global discussion. And I hope that each of us is clear that we can't just leave the issues that have been discussed here in this setting. I hope that at least the majority of us will get off of Zoom sometime and help implement and strengthen and scale up implementation science, informed by some of the really insightful comments that I think we've heard today. I want to add my thanks to Kenny and Brian and all of the panelists who've made this session possible, and to you, Rachel, for all you did to get this up and going, as well as to Arina Kadam, who works with Rachel and who tirelessly helped us get this organized. And finally, to all of the participants who managed to stay on Zoom for 4 hours, which is quite a feat in and of itself. So thank you all, and I hope we connect both on Zoom and eventually in person in the future to move implementation science forward. Thank you so much.